هو بيقولوا غالبا غالبا. بس اهم حاجه بس عشان الريحه بتاعه. اوكي، شكرا حبيبتي، تسلمي، الله يرضى عنك. ثانك يو حبيبي، شكرا، ثانك يو. اوكي، ثانك يو. بسم الله الرحمن الرحيم. بسم الله والحمد لله والصلاة والسلام على رسول الله. Good morning, dear friends and colleagues, and welcome to the second day of the Nursing Symposium. Our today's session is the most beloved session for me. We are talking about the continuous professional development, the key to excellence. It gives me honor to introduce our great moderator, Ms. Ira and Ms. Aisha. They will moderate the whole session. So without any further delay, I will leave the floor for them to introduce our beloved speakers. Ira and Aisha, floor is yours.
Good morning, colleagues. Good morning, everyone. So welcome to our second day of Nursing Symposium. Today, our topic will be about continuous professional development. Continuous professional development is important to all of us, to all individuals. It's because we are able to keep refresh our knowledge, our skills, and we'll have opportunities to improve our training, our skills, and to have a self-development and professionalism. So let me start to introduce our first speaker. Our first speaker is currently an Executive Director of Continuous Education and Professional Development at Military Medical Services in Riyadh, where he is leading the transformation of nursing education across all military medical services in the kingdom. He is also spearheading the introduction and implementation of advanced practice nursing across the Kingdom of Saudi Arabia, as well the Magnet Recognition Program. His experience has progressively increased in scope and responsibility with respect to nursing management of multifunctional departments and hospital-wide performance improvement activities. Let us all welcome Dr. Abdi Kani Kasim, Executive Director, Nursing Continuous Education and Professional Development.
Thank you very much. Good morning, everybody. I'd like to take this opportunity to thank the organizing, the dedicated team for the opportunity to come and share our experiences. Do we have this one here? Yeah. This, oh, green one, huh? Oh, good. Yeah, it's working, yeah. So my title, I would rather to make more because this topic is really a hot topic and it's not fair for 30-minute presentation. And my goal is to deliver a message at every level. Now, yesterday, this slide actually summarized everything that I'm going to talk about it. What does that mean? Nurse should practice to the full extent of their education and training, period. To me, that's it. This is the discussion. What does that mean? This is from IOM report 2010. We go to school, we do our diploma, we do our degree, we do masters, we do DMB, we do nurse practitioners, we do PhD, we have a multiple institutions, we have Prince Noor, we graduated, and guess what? Where are they going to end up? That's why yesterday I was asking if you have ABN, because I hope maybe some of the audience virtually they can relate. We have a lot of challenges. A lot of challenges. People like me who practice MPE for 10 years and been working last 10 years trying to advocate, implement. A lot of barriers. So are we going to stop there? Okay, if that's the case, then you need to close some universities. You cannot have a program running. It's like a factory. By the way, this is a taboo topic, very sensitive, but not me. This is a reality. How can you have a factory producing a product and you don't have a market to sell? Agree? Why are you being quiet? This is reality. So this is the type of things we're talking about. You cannot do that. You graduate people, and then you send them, and then they go back to whatever they've been doing, right? Are we supposed to blame them? No. Why not? You guys know why? That's why I like this to be a workshop. Because a Saudi nurse cannot be promoted, cannot get increment, cannot get anything unless they have master's, wait 2 years, and then they have a senior nurse specialist. And only did they get a compensation. Right? Now, this is a reality. They have to do what they have to do. But for us, it's a really mushkila. Because you are ABN, we invested you to become a nurse practitioner. You come back and then you say, you know what? No, I don't want to be nurse. Oh, why did you go to school? You know what I go to school, don't ask me. Anyway, a lot of things being done, ICN, the transformation, the changing roles, so there is no question about it. The rest of the world, they are working towards, they are giving nurses more advanced role, but every one of them, they talked about the challenges. Suitable education, policy, regulation, you name it. We're not alone. In Saudi Arabia, number of studies being done. And by the way, the role of APN is well recognized. If I listed the challenge, it's going to be huge, and you all know about it. The image of a nurse practitioner, clear recognition, definition, scope, legislation, regulatory, you name it. It's every level, from the frontliners, okay, and this is not unique to only here. When I became MB, my own staff, my own colleagues, right? It took for a while to accept me. Oh, Abdul Ghani, now you were working with us. Now now you're going to pretend like you are a doctor, right? The resistance is everywhere, okay, up to the highest level. It's not a unique. We are not in competition, okay? We're not in competition. ABN is fundamentally a nursing role. This is very important. And this is what I told my novice nurse practitioners. You are a nurse. Okay? Of course, you work with a doctor majority of the time. Your role may be, more like, medical team, but still you are a nurse. So you have to balance between the two. You cannot just, be on one side. You have to really be very, 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 very smart. If you don't be friends with nurses, they're going to eat your life. They're going to make your life miserable, right? We are not in any competition with any other entity within the profession. We are actually complement. We are a complement. If I'm working, the doctor's so busy, I have a time, I do almost everything, and the doctor just do the last minute thing, right? Just to rubber stamp. That's what we do. We facilitate job. Anyway, what I'm talking about is not in the textbook. It's an experience. 10 years I work as advanced nurse practitioner. My background is cardiac. 10 years in Canada. And then I came to Riyadh. I work in King Fahd Medical City 14 years. And then now I'm with the military. Not Prince Sultan, I'm in the corporate, but we start pilot project. So this is the fact. This is what we have seen it. So some of you, if you're planning to do it, maybe you can take some lesson out of this. Shall we talk about how we achieved or what we achieved? Right? What we accomplished and how we accomplished. It's going to take all day if we talk about what we did and how we did it. But anyway, we'll try. Okay? So regulatory bodies, you have to deal with it. Teaching institution, you know, they play a major role. There is no question, because you are the factory producing it. If you don't, there should be an alignment between academic institutions and the hospital institutions. There has to be alignment. You cannot graduates who won't be able to function in the clinical setting. You have to prepare them. Healthcare providers, policy makers, the ABN themselves, if you don't prepare them, if they don't know their role, when they graduate, they think, okay, now I'm APN, I'm a nurse practitioner, oh my gosh, I can do this one, and they have a big ego, and they demand, I want. I say, okay, first show us the money, show what you can actually contribute to the institution. And then finally, community awareness is very, very important. So all of these factors has to be in place, by the way. And then when you're comparing the other countries who already developed, guess what? Everything is in place. Now, individual institutions, they need to negotiate everything because there is no system. System is very important, right? We struggle. You struggle, they struggle. I need my title. I need my compensation. I need my salary. I need my promotion. I need my career pathway. Mafi. None. I need my license. I need my classification. I need my registration. Shall I keep going? Right? The only thing I can offer, I said, don't talk to me about those. Talk to me opportunity to practice, to gain experience, because nobody can take away. We'll give you opportunity to get exposure, to learn, to become a real nurse practitioner. All right? The rest will come. It worked, but they were not happy. But today they are pioneers. One thing I found out, and maybe you can help me, people, money at every level, doesn't know what ABN means, Advanced Practice Nurse. Can you imagine? We are talking about that. They don't know advanced. There is a confusion. Ms. Noura graduates Advanced Practice Nurse. Now, I will explain to you, and you decide if this is right. Because ABN is not a title. ABN is umbrella. ABN is a house that house subspecialties, okay? Anyway, we'll talk about it. Now, some thought-provoking. Okay, what comes to your mind? What is the percentage of these groups in any given healthcare providers? What is the implication? You know, there is a lot of programs of advanced practice nurses, advanced clinical, that who are not ABN or nurse practitioner. Many of you may have advanced clinical practice degree. Does that mean you are ABN? No. The ABN curriculum is a very specific, is a very different than the others. And I can tell you, there is a 3 Bs that differentiates from other ABNs: advanced pathophysiology, advanced physical assessment, advanced pharmacology. If your curriculum doesn't have those three, then forget about it. Don't claim curriculum, specific curriculum for ABN. So if somebody comes to you and you said, oh, because I heard of it. When I try to introduce, many people say, oh, I have it. Okay, so what do you have? You have this one. I say that's a general advanced practice nurse. It's not nurse practitioner. And by the way, you cannot call yourself ABN unless you put something in front of it. And we'll talk about it. If you ask my opinion, this is the most important thing. Who is the ideal candidate for ABN? And I put now MP, by the way. That's what I'm talking about it. You have to have ABN with something, nurse practitioner. Who is the ideal? This is where the foundation is kind of like, okay, loose, all right? When you're accepting candidates to your program, there has to be certain criteria they need to meet, right? You cannot just admit everybody to ABN. You have to have this one, and I'm going to show you a slide. You have to have a strong general and a specialty. You have to have something before you even start it. Because ABN is not nurse practitioners, it's different than any other, because you have to have a solid clinical foundation. Not only that, you have to have a subspecialty. If you are cardiac, you have to come from a cardiac, ER, OB, everything else. You have to graduate a recognized institution. People just keep calling AB and MB. If you're not practicing, what does degree do to you? Huh? If you're not practicing, graduating 5-6 years ago, and then you call yourself you are AB and MB, of course you have the degree, but that means nothing. You're not practicing. If you don't use it, you lose it. You have to have it. This is from Patricia Banner, and this is for me. After working all of these years, this is how I see it. The progression, I love this one. My colleagues, they love it. This is natural progression. You cannot skip from one step. You're like a baby. That's what I tell my students. You cannot skip. Okay, the babies, they have to go through stages, right? You have to start with a bedside nurse. According to Patricia Banner, you are competent, 2 years, same practice, same place, same, right? They come to 0 1 month and then they're moving around, boom, 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 boom. You never become a competent. If you don't follow this ladder, then you're gonna, I don't know what to say. And I don't know the percentage of people who skip. I'm not shy to say this one, because what are you doing actually? You're damaging yourself personally, the profession, the institution, and whoever you're going to take care of it, because you don't have it. All right? Yesterday I asked a question about ABN in Faqiyah. And then they said, we won't have an ER. And then what's her name? She said, we have one wound care, we have brain care. Okay, we have to differentiate here, okay? What are you talking about? It is a nursing-led clinic, okay? They are not ABN, all right? They are nursing-led clinic or specialty, okay? They don't require to have a degree or a specialty. They are experienced nurses, wound care specialists, okay? And then they do more. Pain management, they do more. Vascular, they do more. That's what we call nursing-led clinics, okay? They are within the scope of practice of an RN. And then you have your advanced specialized. Now we are another stage. This usually they have, in the Western we call them clinical nurse specialist, which has a degree, which also under the ABN. But in here I have seen it, they use masters, but they use a specialty area, heart function clinic, big line, right? So they have their own, they are a little bit more. See how we go moving around here? We go bedside nurses, nursing-led clinic, and then we go specialized. So you have to know who they are. And then ultimately is your nurse practitioners. Highest level, autonomy. Many Western graduates of my colleagues here, when they hear nurse practitioner here in the kingdom, they will have shock. Why? They picture your ideal nurse practitioner working in the Western, and they say, what can we do? Hold on. We're not asking them to be same, fully autonomous, doing A to Z, but at least they can do some of the component. Another issue they always talk about is that when they hear about privilege, prescription, prescriptive authority, everyone will have a shock. Okay, we're not there yet. Why you cannot have that? Because you don't have the system in place to support. You don't have your regulatory body, you don't have a scope of practice, you don't have a job description. But what you want to realize is they can do more. Forget about the prescriptive authority. That's only one component. And there is also other ways of overcoming. So when they hear about it, I say, no. Yes, I understand, but they're not going to do all of this, but at least they can do more. This only supports progression from general, specialized, and then you become a CN. You have to go through. You have to go through the progression. So everything, and then you put them in there, and then they're gonna have a reality shock. Boom. If you don't prepare them, if you don't put infrastructure in place, okay, they will have a shock. They're gonna drive you crazy. They're gonna drive everybody crazy. That's why you need to be very selective. You need to know exactly who you are engaging them. Don't rush it. So Faqih has only one now. If you ever try to do it, don't do it unless you have infrastructure system in place. And by the way, the one thing also we have an issue here is everybody embracing APN, nurse practitioner, APN. Since there is nothing, no guidelines, nothing, everybody will create their own. Everybody will try their best to do what they can. And that's going to create even more confusion. All right? So hopefully at what mode we need to have a standardized process. If you leave today one thing, and one thing is just understand this umbrella. This umbrella is the ABN umbrella. ABN is a terminology that houses 4 different specialties. So you can say I'm ABN. If you are ABN, then you are a nurse practitioner, you are clinical nurse specialist, you are midwifery, and then you are also nurse anesthesia. You get now? If somebody told you I'm ABN, I say, okay, ABN what? Okay? Now here we are talking about ABN nurse practitioner. Is it very clear? But the question I'm going to ask myself, and also the Saudi Commission is going to ask, Prince Noura are graduating APN. Nothing, APN. And then when Saudi Commission said, okay, I cannot register you as APN nurse practitioner. I cannot. Saudi Commission actually registers post-diploma degree as specialty, medical, surgical, critical care, cardiac. Why? Their program are specific to the subspecialty. Unlike PNU, APN. We're struggling. I just realized that. You cannot be ABN. Because if you say I'm ABN, give me 4 certificates. People didn't realize it. It took us a while for me to understand. Classification, they acknowledge your degree. ABN, master's degree, when it comes to the registration, you are a general nurse. This is different definition. Okay, they are all the same. They have a master's. Remember, nurse practitioners, bosses, demonstrate competencies to autonomously. This is the word for us, autonomously. Because once you remove that, forget about it. What's the role? If you cannot function autonomously, then you defeat the purpose. But here, we have to balance because we cannot have fully autonomous, right? Because prescriptive. But we can do everything else. Because follow is what? Diagnose, order, interpret, test, prescribe, perform. Yeah, but again, you know what prevents us? Legislated scope of practice, right? We do all of that under the protection. This is, again, the difference between the two areas. This sketch is exactly what I explained to you before. In King Fahd Medical City, the first thing we did, we had organizational structure. Okay. In any institution, the first thing you do, you want to build your workforce, you have to have organizational structure, then you did it. And there was two sections, one for clinical nurse specialists and one for nurse practitioners. And then you can see the different services that we divided into it. Practice model is another thing, okay? Either you can practice like physician alone, okay? In the Western countries, Canada, US, okay, I can work on my own like a doctor. I have my own clinic, I have my own. So that's called physician model. The other one is a joint model. You work with the physician in collaboration, and the other one is a nursing model. The one that we are advocating is a joint model, collaboration. Okay, you have to work with the doctors. So, how did the concept started in King Fahd? By the way, in my experience, the most supportive discipline is the doctors. Would you believe that? They are very advocate for the role. Why? Because they work with them. They know about it, right? Okay? So, but you have to be very careful when you are engaging your new nurse practitioners. Some doctors, they may use them as a coordinator. And the first thing I say, they are not coordinators. They are nurse practitioners. They coordinate care, but they coordinate more. Always you have a champions. This is the champions, King Salman Heart Center. We started in heart failure. This is the ideal for nurse practitioner to work. You work with a doctor. You see the patient your own. You assess them. You do vital signs, and then you come and you sit, and then you give your opinion. Okay, you make your tentative diagnostic or follow up. If they need a further investigation, if they need adjustment of medication. Look, because this doctor, he's busy. And he has especially chronic disease like heart failure, right? He has about 30 patients to be seen. Can you imagine having a nurse practitioner working with him and then seeing maybe half of it, all right? And have more time for the patient. And by the way, it's not a brain surgery. When you are cardiac and you know the stuff, you know what everything you need to be done.
Excuse me, doctor. 3 minutes more, doctor.
Huh?
3 minutes more.
Oh my gosh, 3 minutes.
Thank you.
Okay. Anyway, because there was no infrastructure, it didn't work. And then we have a new group. This group came in from Prince Noura University, and we have to do something about them. See, 2007, this is a reality. Some of you now, you don't know leaders. Some of your staff may already attending some program, and then you hear they're coming. What are you going to do? So anyway, we try to do our best. Dr. Muhammad Hawsabi was there that time. We put a proposal together, Dr. Fahad Qufaili, and we put all the things. This is what I'm talking about it. So you build your own. We saw, and if you look at in the red, I put a red for the prescription authority. This is always a tough talk. We created all the document. See, the other question is, your RN under Faqih, you don't have, you created your own scope of practice, scope of service, job list. So what's the difference for if I create one for my ABN? Why do you resist? Though this is the question. You have it, you did it. It's a homemade. So the commission give you a license, but he didn't tell you what to do, what not to do. Same concept with the ABN/MP. So that's how we went for. This is very crucial because many people will ask how do they function. We have what we call medical. I don't have a control. Can somebody touch the medication?
Ma'am Cora?
Can you touch the medication? So remember what the medication protocol. What happened? Touch the medication for me, please. Why? La. What happened? Here. There you go. So, if you are working in a specific area, we predetermine. Okay, you can scroll down. We predetermine the medications. Hello? Can you scroll? We predetermine, okay, common medications. Yeah, keep going. And everybody will sign it. And those are the limited medication you can within the clinic, not outside. Okay, you keep going, you can go. So this is how you overcome. Okay, you don't have to wait the doctor. Yeah, you can go all the way. You don't have to wait all the doctor, so everybody sign. Keep going. Keep going. Okay, all the doctors will sign. That's how you protect it. Okay, okay, stay here. I think this is for procedures, I guess so. Same concept. Everything they do is under directives, signed by everybody. So, okay, you can stop if you don't mind. Sliding, yeah, just slideshow. Okay, thank you. Anyway, we did the organizational structure. It was very important. And these are the graduates, the 4 of them. 2 of them we put them heart failure clinic. 1 of them we put a bariatric surgery, and one of them we put an ICU. Very important. And but the beauty is, and this is very important, all of them came from those areas. All of them have extensive experiences. We don't have to worry of building their foundation in clinical. We have to just help them, the role itself. Now the mushkila you're going to have it, if you have somebody who doesn't have both, you're going to struggle. And you cannot do that. If you don't have the clinical foundation, the theoretical part, and then you want to now to transit to the new role, it's a double jeopardy. So they were good. It's always very important to engage the stakeholders. This role is a very new, unite buy-in. By the way, all the doctors were very supportive, and they want it. And the one example is Nasra bariatric surgery. It's a very unique, very subspecialty, and she really did very well. So now she's running the bariatric. She set up all the protocols, criteria. What I told them is actually, this is an opportunity to gain knowledge, to become more expertise in the subspecialty. And she did it. She did very well. Outpatient and inpatient, that's where she's working. These are statistics. Can you imagine? Over 400 inpatient were successfully educated. 1,000 outpatients were successfully seen and examined by MP. Over 200 patients were assessed virtually. This is during Corona.
1 minute more, doctor.
Okay, thank you. Will be last one. And this is the protocols she's using it. She created clinical pathway. She's involved project research and membership. Now they grow into 8. There is 8 of them now. This is also the Prince Sultan, now the new group that I have. There's another 8 of them coming pilot project. This is the challenge, the infrastructure, the novice nurse practitioner. You need a career pathway. Also, you need marketing and awareness. This is what I was talking about it. This is a very cool. I have to have a few minutes. This is very crucial. Remember what I was talking about it? This is your ABN. They acknowledge you have Master of Nurse Practitioner, but you only senior nurse specialist. If you do post-diploma, actually we're going to give you senior nurse, senior nurse specialist, medical surgical. Okay, my last one, I have advice. 4 advice, health organization, academic, nursing leaders, and APN. Health organization, you need to put infrastructure and system in place. Don't let anyone go out and do ABN unless you have a place to put them in. Otherwise, you go crazy. Academic institution, you need to look into your curriculum and find out what you're producing it. Are you producing MP, APN, CNS, midwifery? Nursing leaders, you need to support them. ABN, you need to know what you're going into it. Thank you very much.
Thank you so much, Dr. Abdikani, for giving us a wonderful insight about advanced practical nursing. May we ask from audience if we have any questions for Dr. Abdikani? Okay.
Hi, Doctor. Good morning. Yeah, I'm very impressed with APN, your initiative, okay, with the advanced practice in nursing. However, before we advance the practice of nurses, I just want to ask, because for example, in the United States and even in other Western countries, they are advancing and making nursing as an independent nurse practitioners. So here in the Kingdom of Saudi Arabia, because based on, I am teaching a lot of students and in the master's degree, and how do we maintain here like professional equality and professional respect? And how can we protect all of these nurses from professional intimidation? Especially they can practice their, our independent nursing interventions without intimidation from, especially, we want to go out from a decades of notion since the nursing practice has been established that we are handmade clinical practice from professional intimidations.
Thank you very much. I think there should be a topic just covering, you're talking about the work environment, you're talking about the incivility, all right? So that's a different topic, but the way you started, people confuse advancing nursing practice versus advanced practice nurse, okay? So so what you're talking about it, not the ABN, how can we advance the nursing practice? And part of that also is empowering for nurses, critical thinking. Education is very powerful, okay? The nurses, they need to take things on their own. You don't need to be passive. We allow that. We allow that, okay? Don't blame anybody, but accept us. In the Western country, there is no way. We are equal partner. I don't work for you, all right? We are equal partner. So it's more complex. Is the environment, is the system, is the leadership, right? If you go back home, you're gonna become, you are a different person. You are a different nurse, right? You don't go through all of this. You got my point. So this is not an easy answer. It's multifactorial, but now we have a lot of initiatives. In the Ministry of Defense, we have what we call incivility, okay? There is no abuse. It's a zero tolerance. So it depends, and this goes to the leaders, okay? If it doesn't come from the top, I think the nurses will suffer. So you need that to create a healthy work environment where everybody is equal, where everybody is respected. Thank you.
Any more questions from the audience? Okay, so thank you, Dr. Abdikani, for that wonderful presentation. So let's move on to our next presenter. Our next presenter is an assistant professor, head of nursing department in Faqih College of Medical Sciences, with a professional experience as a critical care staff and head nurse in Jordan, Amman. Received his general nursing education in Jordan University, a master in education in Jordan University, and a PhD in nursing curriculum and teaching strategies in Amman Arab University. Let us all welcome Professor Hussein Touma.
لا لا بس البرزنتيشن مش ظاهر. لا لا هنتكلم عليها.
هتتحرك يعني؟
Good morning, everyone. So our talk now about more details. We'll speak about some definitions regarding CBD. I'll select some definitions, and in each definition, they focus on CBD in one angle. The importance of CBD and why we need these activities, identify the types of CBD, discuss the CBD cycle or the CBD process, how we can plan for ourselves, how we can develop the process, then evaluate the impact or the effectiveness of CBD on our practice. By then, we speak about some obstacles or barriers to conduct or to engage in CBDs. So, as you know, these days, we are living in a very changed world, a rapid change world. And the change world, it is the only fixed word now. So we can say that, as the Chinese proverb said, that everything is changed except the change. So the change itself, it is the only thing that is fixed now. So we have to adapt and to accept the change, not to resist the change. It is not optional. It is mandatory for us to accept the change and go through it. Okay. So the responsibility to promote ourselves and to make a professional development for ourselves, it is rely on us. Don't wait for employers, for unit manager, for CNO to plan for you. So you are the one who know yourself. You can assess yourself and start your process by yourself. Maybe the employer will facilitate the process for you. And nowadays we are lucky because all the employers really they are realize what is the importance of CBD, and so many of times they are funded these CBDs by money and by the time also. Okay. Yes, our profession, we are lucky that it is a strategic profession. There is no any healthcare delivery system without nursing. No healthcare institution can operate without nurses. So the nurses now, it's backbone for any institution. According to this report from WHO in 2006, they said that the nurses or nursing professional must be competent, has scientific foundation for their practice, sufficiently knowledgeable to communicate with patients and their families, also sufficient be able to access relevant information and technology alert. Actually, if we look to these skills, as an educator in the college, in the school, actually we cannot provide the student with all these skills 100%. So after graduate, the student or the nurse, the graduate nurse should prepare herself and should competent or master these skills. For that, in order to achieve what is this report asks from us, the WHO, we have to engage in activities and to reach to this level of these skills. I select some of the definition of CBD, and each definition is focused and look to the CBD from a specific angle. The first one, it refers to the process of tracking and documenting skills, knowledge, and experience that you gain both formally and informally as you work beyond any initial training. Here in this definition, you see that we can realize that the CBD, it is a process. It is not fragmented events. We can select what we want according to our interest. No, it is a process. You have to go through it. When we say a process, this means that there is a steps for this process. And we'll speak about this in more details. Also, in this definition also, you'll see that it will talk about the types of CBD. We have two types, formal activities and informal activities. And also we'll speak today what activities that we consider them as a CBD. What is the characteristic that for the events in order to consider it as a CBD. Second definition, it is the holistic commitment of a professional toward the enhancement of personal skills and proficiency throughout their careers. It is the term used to describe the learning activities a professional engage in to develop and enhance their abilities. Also, CBD is a process of lifelong learning for nurses which meet the needs of patients and enable them to expand and fulfill their potentials. Actually, in this last definition, it gives us what is the main purpose of CBD, the main purpose, why we are engaged in the CBD. The first one, in order to improve the quality of care, in order to fulfill the need of the patient. Then after that also, to professionally develop ourselves, to enhance our capabilities and abilities in the work. Okay, so CBD, an activity that contribute to a professional's learning and development. It can be diverse as maybe completing course, online courses, short courses, postgraduate courses, and nowadays, since 2 years, we are provided in the college online courses. We have now three batches finished, and in each batch we are provided 7 courses. So around we trained more than 300 nurses in our courses. This is one type of CBD, continuing professional development. Also, reflecting on work practices. And I believe, from my opinion, this is the most beneficial way in order to reflect the CBD on our practice, a reflection. Try to how to utilize our experience in the hospital, why we are working with a patient. If you use the reflection, this will reflect more positive in your work. Also, researching a new technique or reading a related article, this is also self-directed learning, self-directed activities. You can select what you want, articles, and you read it. So all these consider CBD. So now, summary, we can summarize as we said that the activity can be viewed as CBD as long as it enables the healthcare providers to apply this learning through reflection or a practical application in their professional life. So any activity that we attended, and this activity reflects on our practice, we can consider it as CBD, continuing professional development. When we analyze the title of this, we can see that continuing means it's a lifelong learning, it is an ongoing process, regardless of your age or the stage of your career. So, to what extent you are, at what level or rank of your job, you need to update your skills. So it is not specific for age or for rank of professional. Professional, this means that for all professions, not only for the nurses. So now all professions have CBDs for it. Development to improve the personal skills to improve patient care and also the career of the nurses. So it is for both for the patient and for the nurse. Now I think all of us agree that we need a CBD. Okay. Why? The first reason, to improve the quality of care. To improve the quality of care. We cannot improve the quality unless we gain new skills or update ourselves with what changes regarding the care. Also, Engaging in CPD also ensure that both academic and practical qualification do not become outdated. So either you will go with this change or we will stay behind. Allowing individuals to continually upskill or reskill themselves regardless of occupation, age, or education level. Also, professional development is a key way to improve your practice and achieve the goals. The professional goals means. Some benefits of CPD, as you see here, to be commitment to lifelong learning, increase the capacity of the nurses. So in all the capacities, all capabilities of the nurses that can appear through CPD, stay up to date with changing trends, become more effective in the workplace, maintain and enhance your knowledge to supply a better service, advance the body of knowledge within your profession, and also increase the confidence. So by CPD, you can be confident, more trust in your work, and more confident in providing the care. Many categories for CPD. One of the types that it is appear here, it is either formal or informal education. Formal, we can just differentiate between them that formal, it is structured training or education. Like for example, maybe face-to-face education as what we call is online courses or short courses, distance learning, online learning, short courses, formal on-job training also. And there is informal learning, and it is related to the self-directed learning, what you want to select to read. It includes reading books, journal, manuals, or familiarization with the operation of technological aids, computer, etc. So either formal or informal. Another categories or types of activities, maybe the conferences and meetings. So the conference, workshops, symposia, this is a kind or an event that considered CPD. This is one of the events that we are conducted now. Presentation and papers, also this is a type of CPDs. While you are prepare and present papers in conferences and symposium, institutional activities, and this is very, very important. And really, it is a learning resource. What I mean that it is a meeting, okay? To be a membership of the institution meeting, it is one of the learning process. While we are conducting a meeting in the committees, different committees, you will see that it is a learning process. You can take a lot of knowledge from these committees. Also the accreditation process, either for the hospital or for the program or for the college. So accreditation process, it is a rich area for learning experience. Sometimes you are conducting CPD based on number of participants. So if we have a large number or large groups, we have to conduct lectures, conference, or webinars, as we make in the hospital and the college. Small groups, workshops, small group discussion, journal clubs. Individual learning, this is self-directed as academic detailing, audit and feedback, reading the literature review. All these are self-directed learning. Yes. Now, the new theme to move or to shift from educator focus to the learner or to the student's focus. So, actually, before we are focusing on passively listening to lecture, the participant or the students are passively listen, and there is no participation with the teacher or the educator. Now, we need active participation in learning, and we apply this in our college since 4 years. We replace all teaching methods or teaching strategies in the college. We allow just only for 25% of the lecture to be given to the student, and the other 75% are innovative teaching strategies, advanced teaching strategies, like for example, team-based learning, problem-based learning, small group discussion, etc. Also, before, the educator or the lecturer decide the topic. Nowadays, the student or the learner should decide the topic. You are the one who decide what you need. Don't wait anyone to plan for you. Okay, before it's read a journal or textbooks, nowadays it is not enough to read. We have to involve the student in a problem solving and in simulation or case scenarios. So even our assessment for the student now changed. So we are changing the question to the simulated cases question. Simulated case question. Yes, how we look to the errors nowadays, we have to look to the errors as a learning experience. So we can learn a lot from our errors. So we have to build a culture of safety, a culture of quality that allows the nurse who making the error to report this error. And if this has happened and there is no blame environment, this will lead to a very rich area of learning inside the hospital. Yes. As we said, a CBD cycle, it is a process. And when we speak about process, it is having steps. So as, for example, nursing a process or scientific a process for solving problems, a decision-making process, we have to reflect or to assess first what we need. Assess the need for ourselves first. Then after we identify the need, we have to plan for how to achieve or to fulfill these needs. Then make an action or implementation for this planning and evaluation. So reflection means assessment, to reflect on your work. What we mean by reflection, this means that you have to think about what you have done daily. For example, if you did any procedure in the hospital, you are participating in CPR team, so how you do or participate or your contribution in this team, okay? And if this happen again in the future, how you can perform again, how you can improve your action. So by this, you can assess yourself like what you will do SWOT analysis for yourself. You have to identify what is strengths, weaknesses for your profession, okay? Then after you identify these needs, you can start the planning. And when we make a planning, this means that we have to create objectives and goals to fulfill our needs that we are identified at first. So how will you meet the development need you have identified? What level of competence do you need to achieve? How important are these needs in relation to each other? How urgently do you need to meet the need? Okay, then after that, after you make a planning, you have to implement this plan, make implementation for the plan, then you will evaluate the achievement. Either you achieve or fulfill your needs, partially achieved, full achieved, or not achieved, and you can reassess again. So CBD, it is not haphazardly. We cannot select what we want separately or fragmentally. We have to make a plan for ourselves to see what we need, actually. Yes, regarding the effectiveness of our CBDs, all of us are attending activities and events. Now, if we want to measure or to assess the value of these events, it will worthy for us in the practice or not. Actually, there is little studies about this because it is difficult to assess this concept. There is two main studies conducted regarding this. One by Oxman and Davies in 1995. This study is a longitudinal study over 15 years. Okay, they make a systematic review to determine what is the effectiveness of CBD on the practice. And what they found that didactic sessions like lectures were the least effective in promoting change in practice. And I think all of us agree about this. What's important now to add for the lecture what we call it is interaction. Now, there is no lecture we use interactive lecture. So any events you attended and there is participation, there is interaction, this will be more benefit and positive to your work.
Excuse me, doctor, 5 minutes more.
Sorry.
5 minutes more.
Okay. Another also study by Davies again in 2009, They found that educational meeting and workshop formats improve the practice and patient outcome by only small observed effects. So, what is important for us to know that if you want to attend events and to ensure that this event will benefit you in your practice, you have to participate. You have to make participation and you have to interact in this session. Some obstacles or barriers that we can face while we are looking for CPDs, like for example, time, and all of us facing this problem, conflict with family responsibilities, lack of resources, money, mentors, trainers, lack of administrative support, heavy workload. So this will depend on you and if you are keen to attend or to develop your professional level, it is easy to overcome all these problems because this problem all of us are faced. It is not specific for any one of us. So it is easy to overcome this problem. So by the end we said that, yes, you are the only one who can plan for yourself. Don't wait for anyone to nominate you for workshops or something else. So you have to make a plan and you have to go with this plan. Yes, the employers can help you and facilitate these events for you. Thank you.
Thank you, Dr. Hussein, for your presentation about the benefits and importance of CPD in our profession. So let me ask with the audience, any questions for Dr. Hussein? Yes, Ms. Ashra.
Assalamu alaikum, Dr. Hussein. Thank you first for great presentation, and thank you also for being one of my favorite instructor in my masteral program. I would like to ask, actually, you said early at the beginning that don't wait for your nurse manager or CND to ask you to join to the professional development courses. I would like to ask your advice. How can I motivate myself to join the different courses? Even we are nurses and busy all the time, still, but I need that, yes, I know that I'm lacking some knowledge in this, but I don't have a time. So what's your advice for us to motivate us, all of us? Okay. Thank you.
Thank you for your question. Actually, yes, we have to differentiate between training and development. The training, it is a formal and linear. Sometimes you have to select some specialty or area to train the net, for example, ICU nurse, to be an ICU nurse or emergency department nurse. This is kind of training because it is structured, there is courses, and by the end you will reach your specialty. But the development, it is not structured. Usually it is informal, mostly informal. How you know your needs? As I told you, use the reflection method. While you are working with the patient, with the experience, you can feel what are the weaknesses of your work. Based on that, if you identify your needs, this can be easy to identify how you can achieve your needs. Just use the reflection for work. Thank you. Another question?
Thank you so much. Another questions from the audience?
Okay, thank you.
Okay, thank you, Dr. Hussein. So let me introduce to you the next speaker for today. We all know that coaching and mentoring are two popular approaches that aim to help individuals to grow, develop, and achieve their full potential. So for our first speaker is a Chief Nursing Officer in AVP Health Strategy, Al Madina Health Cluster, our former Chief Nursing Officer of DSFH Jeddah, and an Executive Director of Nursing in King Fahad Medical City. Received his PhD in Nursing in MHSA University, Masters of Bioethics, King Saud University for Health Science, Masters of Nursing in Australia, a Bachelor of Nursing in Australia, and an executive leader with a considerable leadership with a long-standing experience in healthcare and management. Let us all welcome Mr. Ahmed Hausawi with a topic on coaching and mentorship practices in nursing.
Assalamu alaikum. Good morning. It's really great to be here. Back home, I left Faqih physically, but my heart's still bumping with the great memories and experiences actually I had. So thank you again for having me here. Thank you for the organizing team. The topic actually I'm going to touch on, I think it's very familiar topic. So we know what is mentoring, coaching, and the point is how we practice this. But the challenge that I put forward in this discussion is what kind of shift we need to do in order to look into the mentoring and coaching as something that it's not really structural, formal, but something can be done in every time in our life. I want to take you to a little bit of exercise before I resume my talk. So, are you ready for the exercise? Okay, so now I would like to invite you to leave everything in your hand, make your hand free, sit in your chair, just relax. I will give you a little bit of instructions where I would like you to call your memory, call somebody who actually passed through your life experience, and this person touch in your life from mentoring or coaching and help you to move from your comfort zone to something else and go back to the time, long time. Make this person ready in your mind now and just relax. And I will invite you to close your eyes for a while and take a deep breath, hold it for a while, and then take it out gradually. So, are you ready? Ready? Okay, so let's start now the exercise. Just relax, close your eyes, start to take a deep breath, hold it for a while. Take it out gradually. Keep your attention to your memory. Try to call this person. Thank him or her for what they've done for you in coaching you or mentoring you. Take another deep breath. Hold it for a while. Take it out gradually. Wish this person to be always happy, safe, in tranquility. And appreciate what happened to you while this person intervened in some of the momentum of your life. Take another deep breath. Hold it for a while. Take it out gradually. Try to imagine and remember the momentum, the succeed you had, the fruits you cut out of this mentoring and support you had from this mentor or coach. Appreciate that momentum. Take another deep breath. Hold it for a while. Take it out gradually. So let's return back life. Open eyes for those who demonstrated the activity. Did you figure out your mentor? Do you realize what is mentoring is about? We've been through this in all our life. We've been through this in a momentum. Just I need somebody to guide me for exchanging. Huh? Al-Akhdar? هذا. Excellent. أوجهه على الأخضر. Yes, thank you very much. The point is, always when we think about mentoring, we think about growing people. Yes, you can do little when you try to grow something that just for a short period of time. But you can do great when you'd like to grow and harvest harvest for lifetime. And that when we said about mentoring, coaching, building somebody, taking someone from level to another level. And if you call the momentum of our growth and what our parents done for us, in fact, they were mentoring us and coaching us. And sometimes they became an educator, counselor. So they do all these rules while we are growing up to the level where we are now. The best mentors are the people in your life who push you just a little bit outside of your comfort zone. Do you agree? This exercise which we've done so far, maybe it helped you to realize some momentums of way. Yes, thank you. Thank you for the momentum. Thank you for that push I had. Thank you for the instruction, the light. You actually enlightened my way. So where I was able to reach where I am now. But my dears, the challenge that we'd like to discuss today is that mentoring is imperative. No way we need to practice mentoring. Yes, we do it sometimes voluntarily in our practices, in our lifespan. But actually, when it comes to the organization, healthcare organization, when it comes to nursing, this is something imperative. The reason why, let's face it, 3 years ago, we were in quiet mood, safe mood of our BCs. And then all of a sudden, coronavirus knocked our door with no permission. Hey, I am here. And since then, until now, we've seen how the dynamic change in nursing practices. And I want to highlight here, the first point is nursing workforce retention and turnover. When we look into nursing workforce nowadays, the turnover is becoming something really uncontrollable in most of our hospitals and centers. In Middle East, in Europe, everywhere in the world. And therefore, we need to change the way we do. So we need to ask the questioners what we can do different to keep these nurses, to bring them up, to make them able to engage. And let's face it, my dear, look now into this room. Our generation here is really varied. But majority, I challenge you all, we are here either millennials or perhaps Z generation. Are we speaking up to this, to the same slide, take it back to the hospital, you see it. Almost we're speaking about 70% of our workforce are millennials and Generation Z. And now Generation Z, they're here and they're making difference. And the challenge that's facing us, how we can link all this generation with those experienced people, how the experienced people, they can take this generation up to that level where it keeps them mature and engaged. And many studies show now the turnover rate increasingly badly in this particular generation. Some of them, they stay in their business, in their work experience almost for 6 months, and then they just give up. And there is many challenges we know. Healthcare is not like before. We're speaking about technology. Yes, these millennials and Generation Z, they grow up in technology, but the technology, when it comes with its engagement and the burden of work, with too many demands, when it comes to accreditation, when it comes to documentation, when it comes even to the challenge we are facing with those sub-specialties. Let's face it, 30 years ago, we were speaking about medical, surgical, and what else? Cardiology. And now, take one slide of specialty. You will have a list of 100 subspecialties, and what we done in nursing, we still need to do a lot. We need to cope with those subspecialties. How are we going to coach, mentor these nurses, to engage them, to understand, to flow with this? It's not only about the day-to-day work, it's beyond mentoring them in terms of their postgraduate certification, their development, their engagement, their social awareness. And this goes more with the globalization we have. Now in this room here, we challenge, we have more than maybe 10 or 12 or 15 different nationalities. We are bringing here United Nations, and this is the same slide in every hospital. So what we can do to make sure that we have a strong mentoring program and coaching program to bring people, to let the people able to work together. We see it, the challenge of diversity. It is challenge, but at the same time, it's a great opportunity how we can take it back and make a fruitful out of this. And therefore, mentoring is imperative. So these factors, we can build many other factors. And the other challenge now, the big question is, how can we start? How can we put this in place? How can we build the environment where collaboration, it takes place? Because collaboration is the SE node of having mentoring and coaching. SE node is the spark that takes place in our heart, bring this electricity and pumping that small part of our body, while it is important. So if I don't have collaborative practice, if I don't have an environment where people are engaged, people are working together, then the culture of mentoring and coaching will never exist. So we need to move from hierarchiality and the traditions when it comes to our hierarchical structure and moving up to lead with vision and realization and empowerment of our nurses. Hierarchical structure put forward to improve the communication, not to make it difficult, not to make people in silo, but to bring people together. So the challenge is now, and we do have many solutions, as now Faqih Care is going into journey of magnet, shared governance is one of the major components that can help in challenging the status quo of the traditional hierarchical structure and bring people together. We need to move from bureaucratic to innovation and learning organization. Learning organization, how we learn from each other. How we can have that collaborative momentum where people, they work with each other, not only among nurses, nursing community, but how we work interprofessionally fashion with other specialties to make the momentum and keep the momentum of patient experience design there, where people, they understand that our role is not silo, but it's more of collaborative practice. And this is now, it's not about limited, it's about transparency. How we can become transparent to those new generation, to bring them to the level they see everything there. And they'll be able to make the decision. And they'll be able to get the knowledge, the information that it helped them to grow. And more leaders, they need to move from charisma style. Leadership is not about charisma. Leadership is about being real, being authentic, being yourself. And becoming a person who's able to grow people, to make them all around one vision and mission. And this is how we go with what we call transformational leadership. Moving forward from that title to impact, authentic, and make meaningful in your leadership. So leadership is about being positive, being able to build that culture of positivity so people, they can collaborate and work with each other. Leadership is not anymore, to make the environment of collaborative is not anymore about self-interest. It's not anymore about you, it's about we. It's about the service, the patients. Therefore, we're speaking about person-centered care. And here where we can build that, cultivate the culture that can bring mentoring and coaching as something normal practices in our nursing. Anecdotal experience. Yesterday, Mr. Muhammad shared with us very good exercise. I thought to do again, but maybe I will take long time. So I thought to share with you a little bit of short experience with some flavor of mentoring. And when we speak about mentor and we speak about coach, we speak about counselor, we speak about educator, almost we're speaking about water in different cups. Yet there is a little bit of differences. We're going to touch on it. But I will call some memories while I was doing the exercise earlier about the breathing exercise and the gratitude exercise for our mentors. I call some mentors, and I cannot forget them. I do remember this took place early. This when I was in Australia and doing my training. In one of the placements I had, I have to go through a new hospital where I spent almost 3 months, and this hospital was in a remote area, and I have to move my luggage, everything, and sleep in a small porta cabin. and have a different life away from the university. And I know 0 people there, okay? I was the only distinguished nice color there. So everybody knows me there. And then I have to have somebody, my clinical nurse specialist, Margaret John. She was there, not only a clinician to help me in my placement, but she was beyond this. Because we were serving ER there, and at the same time, she was running ER, while doctors, actually, he is in another area, and they call him, and he should come in 20 minutes. But she's qualified to do many advanced intervention. So we just heard Dr. Abdul Ghani spoke about advanced nursing practice. She was doing advanced nursing practice in ER. So she took me there in a collaborative way, and she took me away, not only focusing on my clinical placement requirements, but beyond this. So I learned what is mentoring there. Especially with somebody who's just foreigner in a new area, in a village, hospital-based, and he should be taken carefully, not only to teach you cognitively, but to teach you more about social, and look at me from not only a person that just come for education and training, but a human being who have full story of life. And that's what make difference in my placement in that 3 months. Thank you, Margaret. The other person is Dr. Wafa bin Ali. Dr. Wafa, when I returned back from Australia, I came in, when you come back from scholarship, you came in always with that building of ideas, and you want to do, you want to change, and you come, I'm here to save the organization. She called me down, تعال Abu Amr, تعال Ahmed. She said, just hang on. She said, tell me what you want. I went, I asked, I need a position. I want to be the nurse manager. I'm now qualified. I have master's degree from Monash, Ishada. She said, just cool down, Ahmed. Nursing director said, you need to do more rotation. She gave me big tasks to do. But Wafa, thank you, Wafa bin Ali. She's mentored me with her experience in building certain objective and make a plan of my returning back. And she supported me not only in building that objectives, no, but she was with me the whole line until I fit in. And without her support, after the support of God Almighty, I won't be able to stand here speaking as a chief nursing officer, experienced chief nursing officer. So she put the light for me, and I cannot forget this for Wafa bin Ali. She's now one of the faculty, senior faculty, National Guard Hospital. So give a big round of applause, please. You know these people here. So I joined Faqih Care in 2019, December 25th. Before that, I supposed to put Mr. Muhammad Faqih picture here as well. So Muhammad Faqih took me a while as mentoring until I reached there, Faqih Care. And then somebody here with the name C&D, Miss Sholi, she helped me a lot to engage. Please give big round of applause to Sholi and Muhammad Faqih. So they engaged me heavily to Faqih Care, they mentor me. And I was mentee. Because mentoring is not about the knowledge you have. It's about the needs that you have. And the person who have ability to support you and give you that needs, that is your mentor. So they mentor me very well. They take me to the stage until I found out. I remember Sholi used to come, Ahmed, let's do this. I said, Sholi, you are my mentor. Just do it. I need 3 months to fix in me here. So she helped me a lot. Thank you, Sholi. Thank you, Muhammad Faqih. Khadra Umar. Do you know Khadra Umar? She's our current chief nursing officer. Give her a big round of applause. Khadra Umar was among all the C&D's leaders. Yet, I found out she has strong interest to do more. I do have one-to-one meeting with the team. And I'm always we go with mentoring and coaching in that session without agreement. It's just, we're doing it as, يعني كل يوم we sit together and talk. I took permission from you, Khadra. And time by time we're building and discussing. And I found, well, it's time, Khadra, to go more in that line. And I was rotating the rule, sometimes for Khadra, sometimes for Sholi, sometimes for Sandra, sometimes for Jamaica. And I'm going in rotation, not only just to build someone, but to build people in that capacity. So I found it interesting to see this. In mentoring or coaching is not the task that you know, it's part of your duty of care. Whether you are a manager, you are head nurse, find somebodies, find group of people and bring them to that level. Give them chance to lead, be generous in that. And that it was really remarkable. And I'm so happy to see Khadra where she is now. Thank you, Khadra. Thank you very much. Professor Mustafa Budrik. Yesterday I was just almost like freeze tongue when I came and I saw him. He's currently now my supervisor in the PhD I do. Almost 1 year to go, inshallah, to finish. But imagine, I was not planning to make my PhD at all. The year when I invited him here, after I finished my, what we call the RCSI fellowship, he said, Ahmed, why you don't do your PhD? I said, خلاص أنا شيبة. Why PhD now, after 28 years? He said, no, please go ahead. Since then until now, he's mentoring me from all the level, engaging me. Recently, I done a presentation in Indonesia about my proposal, engaging me with everywhere, putting me in network everywhere. And I'm really grateful. And thank you, Professor Mustafa, for what you're doing. The question, what is your experience with mentoring as a mentee or mentor? I know you're going to list many mentors. Try to figure out what this mentor has done for you, what kind of characteristics they have, and say, well, what I can do for others, I will go more. With the permission of Cora, let's go through this YouTube just for 1.5 minutes, and then I want to get your insight afterward. I will do Mr. Muhammad Faqih style after it, okay? So the YouTube is running now. Just enjoy watching it. Can we? While Cora is opening the YouTube, I want to ask you a question. Do you find this topic interesting? Do you find it's really new? Mentoring, we do mentoring every day. Huh? We do it every day. YouTube is going to be ready now. So what we're going to see somebody helping somebody else. But I want you to figure out the motives and figure out the situation. I'm the only universe, I cannot dance to this music. Okay, here we are.
Who's what stripes? NBA during her performance. Who's what stripes and bright stars through the barrel this fight? What's so gallant is
7-year-old Natalie Roth found out firsthand what Hollywood jitters are all about.
I started singing and I took the mic and a frog came to my throat and I was really mad at that frog, so I asked somebody to take it out.
It was a combination of referee Jess Thompson and sympathetic players and fans who persuaded Natalie the show must go on.
Oh, say, can you see by the dawn's early light what's so...
I was just kind of watching her and seeing what was going to happen. And she was looking around for her mother and just kind of searching people's eyes, and her eyes caught mine. She just looked. I looked at her and she looked at me and I said, do you want to go back out there? Come on, I'll go back out there with you. I'll help you.
Or the
think for his efforts there, Jess Thompson ought to get a week's grace from booing from the fans.
All right. Okay, that's great. What did we see? Support. What is more? Huh? Coaching. What is more? Huh? Caring. What is more? Encouraging. What is more? Huh? Huh? Guidance. What is more? Volunteering. Beautiful. What is more? What is the motive of that participant in that gathering to move from his seat and support that little girl? Compassion. So, what is this video revealing a meaning to us when it comes to mentoring and coaching? I need somebody to take the mic and speak up. Or maybe I'll select like Mr. Muhammad did yesterday. Just be careful not to fall. Of course. Therefore, I'm looking for the stairs. Lessons learned. Anybody want to share insight about what is the meaning of this when it comes to mentoring? Can you see mentoring is not a request? Mentoring can happen every time. But we need to open the ears of empathy and compassion. And we need to move forward from our place and go to that place and help that person, the newcomer. Help that leader who is struggling. Help this person who's potentially to be a leader. Help this person who's potentially to be an educator. Help this person and do it. And the beauty of when you do, what you're going to feel, you feel good. And when you feel good, you'll do more goodness. And that's the beauty of mentoring and coaching others. The $1 million question. How we can initiate and maintain mentoring and coaching in an organizational level. This is important. And always when we speak about starting something, we're speaking about leaders and the role of leaders. Mark Riegel is one of the theorists. He actually brought a very nice theory, although it's old, but it's very important and touching our life nowadays. He said that leaders, they either practice with Y gene or X gene. He says that leaders with Y gene, those who are able to see potential in their staff and then take this potential as part of their practices, attitude, and then this will impact the way they lead. So he said, now when I have leaders who have assumption and expectation on their staff in terms of support, they're practicing support, they're practicing empathy, they're practicing engagement, positivity. What happened? This is becoming a leader's behavior. And then it impacts the organizational environment and then employee behavior, and it became in a leader assumption. Then the leader will say, well, yes, my attitude about my staff is right. This is how I see the impact, and it's vice versa. So therefore, leaders with Y gene, they're able to see the staff are potential. When I see my staff is potential, then I will do something about it. And when I'm practicing this, the other leaders around me, they will do the same. And we know when you go for change, always change cannot start with a big cohort. Change starts normally with innovator. Innovator, they maybe constitute about 2% of the total of your staff or leaders around you. And then this 2% of innovators, they will invite early responder, who are maybe about 36%. A late responder, they will follow up because they will see the beauty of the work. So start with the leaders. Leaders put the tone for mentoring and coaching. Does it make sense? Whoa, Mafi makes sense? So let's challenge then, and we'll make it more. And in order to take more steps in that, we need actually to move from I am to what? We are. And we need to put, that's what we call shifting the mindset. So we are not pushing people, but we need to pull people to us. So let's take example. So you don't need, when you try to help somebody, you don't need to practice that. I want to show you how I'm clever. and you are S. Astaghfirullah. But we show people, no, I'm here to help you. Tell me, how can I help you? When you put this invitation as a leader, as a staff, it's really helped. Do you remember the first day you start your job in nursing? Do you call that day? Ustaza Fatima, can you share us your insight? No problems.
That means you are very old, Mr. It was the first day for me. It was before 23 years. And it was with Mr. Ahmed in An-Noor Specialist Hospital in Diabetic Center. So it was my first day in the career. So we are Sheba. He mentoring us. He pushed us. He teaches us how to do right things at the right time from the first time. And still, mashallah, Mr. Ahmed, you are giving us the inspiration now to do the best. I want to be like Mr. Ahmed. So inshallah, our next plan is to continue my PhD.
Allah يديك العافية مريان. Thank you very much for your insight.
يعطيك العافية. It was great.
Thank you. يديك العافية. Well, I think I'm younger than her, huh? No, of course. Ustaza Fatima, thank you very much. I just remember those days. Thank you for making great difference. Well, I think we do have those experiences. So when we work, when we practice in any form, just we try to invite people, not actually to ask him to come, but make it in the model and go. Okay. And how to take more this into the next level. Again, it's not about me, it's about you. There's a famous book called I and Thou and I and You. The author of the book says that people, they see each other either from I and it. I see you as an it, and I see myself as a you, or as I am, in that the context of full human being with the full story of life. So he said that in order to do this, it will help us when it comes to mentoring as a leaders or as a staff. I see any member of one of my colleagues, I see him or I see her as a you with the full story of life. She is not a nurse. No, she's a human being. She's a human being practicing nursing. She has emotional needs, psychological needs, social needs, and so on. She is not educator. She is a human being practicing education. She's educating people, but she has a full story of life. And when we do this, we can see how we can support those who are struggling around us and becoming more effective mentor. So what results can be expect out of this? Well, of course, escalate the confidence and support people, and as you name it all. And this is how to return back to our practices. What is mentoring now? Anybody can define mentorship? I think we know all what is the definition of mentorship just from the experience we had. Everyone here has that experience and remember that momentum. Mentoring happening from those who are able to help you in that stage of time, in that circumstance, take you to the level where you should be placed. And when it comes to coaching, the difference here where we're speaking about, I coach you when I figure out that you have certain objective to meet, and this objective needs follow-up, and also it has more of what we call organizational agreement between me and you as a coach. But at the same time, it is interchangeable with mentoring, because mentoring is more holistic. It does not require certain objective, and we cannot measure it. While coaching, we can measure coaching, especially while we go stage by stage and objective by objective. But the key point here is what actually make us strong when it comes to mentoring. Mentoring is a brain to pick, an ear to listen, and a push in the right direction. And I want to line here on the ear to listen. It's not about your ability to listen. It's about your ability to have that empathy, an ability to feel others. And when you feel them, you will do something about it. All right? I just want to jump on this. So we'll touch about the benefits, we name it, but the most important that actually we are growing cohort of people. We are growing people. We are harvesting a great outcome of people for lifetime growing up. And this is the difference when we practice coaching and mentoring in our healthcare organizations. What is the characteristic of good mentor and coach? Together, what we see here? Caring, do you agree? Calm, adaptable. What is more? Trusting, possess self-awareness, role model. Call those people you just mentioned in your memory when we started the session. You'll find them all have this list, and maybe more. They have effective listening skills. They are able to listen. They're able to see people in their right picture of being people. They're observant. They are non-judgmental. And they observe even the behavior of people. They're able to focus on the strength. And when you want to mentor somebody, don't just say, well, I see you have a problem in this, and I think you need to fix this problem. So what happened here, I'm just closing all the window of hope, and I'm looking at you from your ugly face and say, well, no. Moon has two sides. It's a light in one side of the earth, and yes, it is dark in the other side. So when we put our focus on light, people, they will see it, and we'll be able to bring them up. When you're mentoring somebody, you need also to be able to have more of agreement and more of, yes, it's a mentorship agreement. And that's what we're going to see it in more steps in future now. So, and of course, share knowledge. You need to be generous. Generosity is important. Yes, you do have the knowledge, but this knowledge is not only for you. Just bring it up. Share it with people. Give them access to it. Guides, advice, and so on. So you have a list of it. But the key point here is just to be human when you deal with human and mentoring them. And I mean here human by the way you deal and the way you look at them in that human context. So it helps a lot and it makes difference. This is one of the tools that very famously used in coaching people, which they call it grow. And grow, it goes that you need to set certain objective with that person. And of course, to have more of reality and knowing what is the situation now and the context, and then a little bit of options and will. But most importantly, in using this tool, take picture if you like. I will share with you the slides. The grow is very famous. You can just Google it. It's helpful. The key point here is your ability to listen, an ability to make open question and listen more, and open more and listen more. Try this person to get where he should be or her or she should be. Mentor empowers a person to see a possible future and believe it can be obtained. Can we recite this together? Okay, let's count. 1, 2, 3. I cannot hear you. Last moment, again. That's simple what these people done for us. Thank you for everybody shared his or her mentoring momentum with us. We go next. Now, this is the last 2 slides. Here where I'm going to put you more in practice. We are, in Faqih Care, I'm still saying we are. We are Faqih Care. The love of Faqih Care is still remaining and will remain because the memory and the great achievements, guys, you're doing is really unforgettable. So putting in place mentorship program, you need to start firstly by putting the model. As we said earlier, as a leader, you need to practice this in all your level, whether you are in C&O level, in your middle manager level, but practice it, model it with people. Open that window to people. Listen to them, coach them, mentor them, instead of counseling, put counseling alone. Convert counseling to coaching and mentoring. Counseling, even if there is a mistake, mentor that person. Yes, we overcome the mistake action, but I want to take you to the healing time. And this is my role as a leader. And when we practice this, it became a culture. But you need actually to make it. And then start to put that initiation, announce for it. And invite people who wish to be mentored. Many people, they wish to be mentor, have that list of mentorings. And when you have those mentors, these mentors should have certain characteristics, of course. You can be a mentor by, yes, I feel I can be a good mentor. But at the same time, there is something also beneficial for the organization. So the organization can determine certain competencies or focus area that they need these mentors. And announce and get people to list themselves in a mentorship list. And then open that invitation to people and negotiate by building up a contractual agreement between the mentee and mentors. So people, those who wish to be mentors, to be mentored in certain specialties, certain way of growing. If, for instance, you have career ladder program, which I'm sure Faqih, they have a beautiful career ladder program, they started it. And when you link mentorship with career ladder, what you do here, you are opening opportunity for people to grow. Yes, I have this ladder. At the same time, I have somebody can hold my hand and help me to cross it while I'm going into this journey. Facilitate learning, advocacy, and professional networking. And this is very important. So when you do this, you're opening up for people, give them opportunity to link with each other, and also having them to sit with each other again and have more of feedback to see the impact of this. And get chance as a leader of that unit, or perhaps the champion of the mentorship program to meet these people, to get their insight about their experiences with each other. Some organizations, they use certain tools like documentation so they can put some points and feedback. And of course, evaluation is important. Evaluation is not to say you are good or not. Evaluation is more of how I feel about it, how I benefit from this mentoring program. And this is a little bit of practical steps in how you go with every single phase, but it's more of, in general, you need to start this by exploring this and open it for people, showing them a model and invite them to go. And of course, make environment for this. So here about the negotiation of how you build the learning goals, maybe that can be reflected in a sheet of mentorship and that people they can work with. Phase 3 is more of how you open more of resources of knowledge for people so they can acquire and get, especially if you have career ladder program, so they know how I'm going to go through this. For the novice nurses, the newly comer, they have mentors at the starter of their relationship with the organization. Yes, we have preceptor, but mentor is different. And try to bring that mentor from the same background and culture of this person, so this person can go more deeper with this mentee and help him to grow within his or her first experience. I think I reached to the destination. But before I say goodbye, I want to say thank you for being all these momentums, listening to something that you know. Because all of us here, we know what's a mentor, what's the mean to be a mentor and mentee. We've been through this experience in our social life. We've been through this experience in our beginning. We know this when we had a mistake and somebody hold us there. We know leadership, they have a rule in this. We agreed that leader, they are the people, they are the one putting the tune for it. And of course, when you do this, you can model it. And people, they see it in your practice. And here where you can put a structural program to build your mentorship program. Thank you. God bless you. Thank you very much.
Thank you so much, Mr. Ahmed Awsawi, for that inspirational topic about coaching and mentoring. So for the audience, anybody has a questions? I think Ms. Ash has a question for you, Mr. Ahmed.
Good morning, Mr. Awsawi. It's a pleasure to see you today here with us. Actually, I have one question. I think most of the staff, they are confusing between the preceptors and the mentorship. So can you just explain to us what's the difference? What's the different rule for each of them?
Well, thank you very much, Aisha. Thank you for your words. Preceptorship is a task that's given to somebody to help a new person to achieve certain goals in a specific time with the clear tools of building up this person. And normally it has certain context within that organization. And it has a mutual agreement, which goes in the same way with mentoring. But in mentoring, we don't have certain objectives. But we do have sunum bonum, what we call overall objective. So I know, for instance, I will say, well, I need you to help me because I want to be charge nurse. I want to be a charge nurse. And I need you to help me to be a charge nurse in few years. That's how is the big goal I put. But when it comes to preceptorship, for instance, I will say, well, you've been assigned as my preceptor as I'm going to start to be a charge nurse in 3 months. And this is my objective sheets. So we will go through it and we'll meet every while and then to review it. And we can measure this because we do have 2 weeks meeting with the preceptor, preceptee to see how they're growing, how's the learning take place. However, with mentoring, mentoring is more of open platform. It has somebody who will sit with you in a specific timing, in a quiet timing, where you agree and discuss in a holistic picture. While preceptor and mentorship can be sometimes cocktailed together. Because if you have a wise preceptor and mentor, that's a gift come to you. So this person will finish his or her role in preceptorship. It is 3 months, but he or she will hold your hand the way you go in that particular organization. And maybe even if the relationship divorce, like if you meet, if you go away and then still your relationship is taking place. Mentor, sometimes they can be life mentors. I hope I satisfy your question.
Thank you.
Aisha.
Thank you, Mr. Ahmed Hausawi. Madam Basant,
Thank you, Mr. Ahmed, for the very inspiring lecture. Actually, I have a comment rather than a question. I have been learned in a very difficult way. I saw in my life while I was junior, and I'm still junior, صح? I'm very young. I saw in my life a very, let's say, very bad character of seniors and charge nurse. And I swear by God, never to be like them. It hurts, and I cannot forget those 3 people till now. Since I was in my internship within 2 or 3 years back. Huh? Don't think more than this.
3 days.
3 days. But really, wallahi, more than 25 years, and I cannot forget. She was very aggressive. She was very competent, but aggressive. She was very repellent person, and I swear by God, and I don't have to be like her. Really, because I cannot forget, wala forgive, 3 of them until now. If you have any advice for me, it will be great.
Well, thank you very much. It's more of forgiveness. Well, I think the great advice that you still remember their characteristics. And you're still telling to your audience, your students, your colleagues, that please guys, be away from these characteristics, because this characteristic cannot make you a great mentor, nor a great leader, nor a great human. So I think that's something you share very important. Yes, we learn from good story, but also we are learning from opposite ones. Thank you, Madam Basant.
One question more, Mr. Ahmed, from Dr. Hussein here.
Thank you, Mr. Ahmed. Actually, it's not a question, it's a comment on your answer. Just I want to add about the question of Aisha. What's the difference between mentor and preceptor? Actually, maybe there is some light difference between them, that the mentor, it is highly qualified person. Should be just consultant and more than consultant. But the preceptor, it's okay, it's experience, there is experience, but not highly qualified. Maybe this one. The second one also, the ratio between preceptor to preceptee may be 1 to more than 2 or 3. So the preceptor can be preceptor for more than 2 or 3 preceptee. But usually the mentor, it is 1-to-1 relationship. Thank
Excellent.
you.
Big
Thank
round
you.
of applause to Dr. Hussein. Thank you very much. And I think this is important point to see the preceptor has also limits, while mentor can have it open. And again, as you said, always mentor, they have higher knowledge in a different form, in a social form, in a work form, in a different forms. Yes, totally agree. Thank you very much.
Assalamu alaikum, Akh Ahmed.
Hello, Ustazana. Hello, Allah.
Thank you so much for such an inspiring presentation. Yani, we always learn from you, and I would be very happy to call you my mentor, if I may say. And we always learn from you. I have just one comment for Aisha, and from your question, and again, another inquiry for you. The comment of Aisha, mainly the difference between mentorship, preceptorship is the formality of the relationship. So a preceptor is more or less a formal relationship, where, as Mr. Ahmed said, it's meant to have objectives. A mentor is an informal relationship. In a preceptorship program, you sit with your preceptee in a unit. In a mentorship program, you can be in the coffee shop having a cup of coffee and having a discussion. That's the main difference between both. And Mr. Ahmed, it's a beautiful concept. Our generation, maybe me and you, Shebas, we were more patient, more tolerant. We wanted to learn, and we used to look for mentors, right? Of lovely people you've been with, and probably the same for me. But our new generation of nurses are way smarter than us, way faster than us, way more advanced in terms of the way they think. And I can tell you personally, even I'm having some difficulties in mentoring some of those new generation nurses because of the major differences they have in the way they think. Any tactics, any advice you would give us on how to approach Generation Z in terms of mentoring and coaching?
Well, thank you very much, Mr. Muhammad. This is a very big question. And I see your smile. Because the day-to-day issue we're facing even in our houses. Dealing with the new generations, it's something that I see it opportunity, in fact, because it gives us more ability to exercise emotional intelligence. And one of the major components of emotional intelligence is empathy. And empathy, it's require you to be more active listener and humble, to go and understand their situation and the time that they grow up. One of this generation, he is a leader now, or she is a leader. The first time I joined the place, she sent me a message, said, well, Mr. Hausawi, welcome aboard. I want to be better than you one day. Well, I said, this is something great. And then I met her, and now she's doing a role. She's doing a leadership role, although she's still young, but she's very enthusiastic. She has the knowledge, she has the skills, but she needs mentoring here. So now I had a deal with her. Just she come to me, once in a while if she has a problem, but she may come with the big issues. Yes, I broke the cup, but don't blame me. So she came into you, not to blame her, but rather to listen from her and just share with her that empathy. Therefore, I highly advise that to deal with the new generation, we need to bring that exercise and gym of emotional intelligence, self-awareness, self-management, empathy, relationship management. These four major components which make us to deal with the cross-generation and a difficult mindset of staff, leaders, clients, situations. And I think that the vitamins I highly recommend that every minute we have one. Thank you, brother. Thank you very much. Thank you.
I think the idea is clear now. Thank you, Dr. Hussein and Dr. Muhammad, Mr. Muhammad. Now can we ask our presenter to the stage for the token?
Would you please, I will ask all our presenters to come to the stage just to get a trophy, and then we will have 5 minutes break, inshallah. تفضلوا يا جماعة. Can I ask Madam Shaibi? Madam Shaibi, would you please come? Five minutes break إن شاء الله. Will come 11:07 إن شاء الله. أيوة 7 minutes after 11 معلش for the sake of the time معلش. معلش يا محمد بس اتصل نادي الموديريتورز بس عشان يقعدوا عشان نبتدي السيشن. بسم الله الرحمن الرحيم. Welcome back. It was a very short break, صح؟ إن شاء الله during the lunch break we will have 1 hour. So we will enjoy the lunch and the break. But now for the sake of the time, let's resume our program. طيب, let's resume our program with the very interesting 2 speakers. I will leave our beloved moderators to introduce our beloved speaker. Leave, floor is yours, dear. يلا يا عائشة.
Welcome back. So the next presenter for today, she is our Director of Magnet and Professional Development at Dr. Sulaiman Faqih Hospital. She is a registered nurse and she has Bachelor in Psychology. She has postgraduate certificate in nursing education and nursing informatics. She is one of the certified NRP instructor at Faqih Care. In her role, she leads the planning, development, execution, and evaluation of nursing continuous profession development activities, including CME and ANCC and NCBD activities, and quality improvement activities in nursing division. She is also leading the magnet recognition journey at Dr. Sulaiman Faqih Hospital in collaboration with the magnet component leaders. She is a nursing informatics Legion staff to facilitate the EMR implementation and updates for nursing division staff. I hear and I forget. I see and I remember. I do and I understand. So this will be our topic for today with our beloved Ma'am Shaibi. Please welcome, I need warm welcome for Ma'am Shaibi Joseph.
It's okay, it's okay, it's okay. Here, ma'am, sound. So good morning, everyone. It's my pleasure to present the topic, which is learning by doing. It goes with, or it refers to the theory of education expounded by the American philosopher John Dewey and the Latin American Dr. Paulo. So in the world of healthcare, success and failure can be a matter of life and death. That said, to be a great nurse, any healthcare professional for that matter, devote yourself to repeated, meticulous practice. The word repeated, I would like to repeat again, the repeated, meticulous practice in a real world setting and apply what you learned in clinical setting. So to discuss a productive method of learning as it helps us embed knowledge into our memory. We know that our short-term memory can retain and recall information only for 15 to 30 seconds. And none of us want to forget things which are important. Maybe at the time comes, we don't recall it and we will have the bad feeling. So how can I shift my short-term memory to the long-term memory? Because the long-term memory can recall indefinite period of time, any information. So my role, my responsibility, and each of us responsibility, how can I move my information from short-term memory to the long-term memory, which is going back to the discussion of learning by doing. And this topic is a continuation of what Dr. Hussain was presenting before, the different style or methods of learning. So if you look at the learning pyramid, which was developed by the National Training Laboratories, only 10% of learned information can be remembered or recalled or retained if you are using reading as the study method. While 90% of information can be retained and recalled if you teach others. I know that each one of us, we are a teacher, either for our new nurses, for our patients, for our colleagues, every day. So what is the most important thing in the learning pyramid? You can see the top one is the lecture. We have total 7 methods of studies. And many more you can find, but the most common. And there is no score for the lecture, 0. So it means that if you are using only lecture as the teaching methodology or the study method, your percentage of retention of memory is 0. Yes, reading is better than lecturing, but still it is considered as one of the least effective method of retaining or recalling the memory. Audiovisual can retain 20%, and the audiovisual study method is much better if you combine with any other method of study, not alone audiovisual. So in the learning pyramid structure, out of the 7 methods, demonstration is the first interactive study method. So it can retain up to 30% of information. Discussion always stimulate thinking, critical thinking, so it can lead up to 50% of information or recall information for 50%. 75% you can remember if you practice what you have learned. This is called discovery learning. The last one and the best one, teach others. That's why I have chosen this topic, learning by doing. Teach others by teaching. Learn by teaching. The key to subject mastery is teaching to others. Why? When you want to teach somebody, you want to master the subject very well. So today, if I want to talk about learning by doing, I need to study the material very well. So both of us, we are going to be a winner. The learner and the lecturer. The most common form of teaching is peer tutoring. And it's happening always within our healthcare activities every day. One of the main activities that should occur in an effective study group is peer-to-peer teaching. So today, I'm going to share a story, or I'm going to share an experience of using this initiative which is implemented in Dr. Sulaiman Faqih Hospital. One of the strategic priorities, or if you consider all strategic priorities, clinical excellence, service quality, patient safety, patient and staff experience. So anywhere we are talking about quality, patient safety, patient experience, staff experience, we want to do something different to make everybody happy. every day we want to make something different to make everyone to be more safe and comfortable. For that, we have selected a topic, 7 habits of highly effective people. So one day, our nursing directors at Dr. Sulaiman Faqih Hospital, we got an email from our CEO, Mr. Lee. He said that, let us have a campaign on 7 habits of highly effective people. And we want to choose a different learning methodology, not just a lecturing from one person and all other people will be listening. No, we don't want to go for that. Let's do the reverse teaching methodology. So let the staff nurses teach the nurse manager or directors or educators. So why did we choose this topic? Because this has a major impact on our strategic focus area. Let me go back one slide. So 7 habits of highly effective people. It has a role in clinical excellence, service quality, patient safety, patient and staff experience, operational excellence and innovation, education and training, and sustainable growth. So if you go back one step, habit number 1, be proactive. A leader, we all are leaders, isn't it? Maybe without a title, with a title or without a title. We have nurse manager role, educator role, staff nurse or chief nursing officer. But we are a leader. One day or the other day, we are a leader. Without a title, with a title. So 70% of the leaders, the study shows that 70% of the leaders are not prepared very well to be a successful leader. Why? Because they are not following the habits of highly effective people. So let me introduce this topic. I know that I borrow this topic from Stephen Jovey. He is an American author, and one of his famous book is 7 Habits of Highly Effective People. And whoever did not, how many of you have heard about this book, except the speakers who did the lecturing on this topic before? Many of us. Other audience, it's my humble advice. Today, during your break time, please Google to this topic, 7 Habits of Highly Effective People. So be proactive. Being proactive can prevent. So you are preventing, not repairing. Don't wait to repair. Number 2, begin with the end in mind. Number 3, put first things first. The first 3, talking about ourselves. How can I improve myself? The next 4 is talking about the teamwork. Put a win-win solution. So it's not a like a competition. It's about consideration. Consider your colleague so that both of us will be a winner. Seek first to understand, then to be understood. Seek first to understand your colleague, then you expect you to be understood. Synergize, encourage teamwork, and sharpen the social, psychological, mental, physical. Develop yourself. Find your own time to relax so that more time for you to do the better things. So my topic is not about 7 habits. My topic is about learning by doing, but we have selected this topic, and I hope everybody can learn more about this topic later on. So learning by doing, what did we agree at the beginning? Okay, let's have a friendly competition between the nurse manager. So we have 7 habits. We have selected 2 teams for each habit, and let us do a competition. Who will be the winner for each habit? That winner, her presentation material will be selected to teach the entire organization. So that speaker who is going to do the presentation, she is the winner, and the audience is a winner because she needs to learn about that topic before she teaches the audience about that topic. So we had a friendly competition during September 2022. 14 nurse managers presented. And what did we agree after? Okay, let this selected nurse manager do a training and workshop for the entire nurse manager, nursing directors, and the educators. In November and December, we are doing charge nurses are teaching the bedside nurses, and the bedside nurses are going to come back and teach the educators, directors, and the managers. Reverse learning. Why? Because not one person is mastering the skill of this topic. We want to have at least more than 400 nurses to be mastering in this topic. This is one way of learning. Because learning by doing can be used at any age. Children wants to do this technique. They want to practice. Adults, yes. Because if you want to learn any new topics, new experience, practice learning by doing. So these are the names of our nurse managers who went through our competition. As you can see, Lisa, Aimee, Marjorie, Mona Lisa, Irish Ann, Miss Amma, Rachel, Hannah, Daulat, Percival, Deborah, Pauline, and Sarah. Thanks to everyone. Thanks to everyone. As you can see, we dedicated like a half day over 4 days just to finish the competition. Healthy competition. Organizational support and judging panel. We have a great support from the judging panel. Miss Sarah is coming at the right time. Thank you, Miss Sarah. She was one of the judging panel. So as you can see, our Chief Executive Officer, Mr. Lee, our Risk Manager, Dr. Lamia, and our Patient Experience Director, Ms. Sarah, they were spending 4 days of their valuable time to evaluate who is the best speaker who can deliver this material in a simplified manner to the bedside team. They had hard time, isn't it, Ms. Sarah? Hard time to identify a winner. And everyone was a winner. Because one of the 7 habits is win-win solution. Isn't it? Everybody need to be a winner. Not only that, everybody was competing each other to be a better and best speaker. So everybody was a winner. As you can see here, some of the pictures, what we had during the training session, like even our CEO and the patient experience director and our risk manager, they were participating in the interactive activities. Why? As Dr. Hussain mentioned, if there is no interactive participation from the audience, don't expect your audience to learn. Thanks to the organization who supported us to get our American Nurses Credentialing Center, Nursing Continuous Professional Development Accreditation. Thanks to Ma'am Basant for being the leader for program director for our ANCC and CPD accreditation. One of the requirement is no activity shall be done without an interactive time during the session. So we learned a lot. Not only that, aligning our bedside team to the strategic priorities of the organization. You want our patients to be satisfied. We want our staff to be satisfied. Every leader needs to exhibit 7 habits of highly effective people in order to make everybody happy. So if the leaders are like characterizing or demonstrating these habits, our bedside team is going to take it to our patients. Our patients are happy, our caregivers are happy. Aligning our bedside team to the strategic priorities. And staff experience and comments after the competition. One of the speakers said that, I was forced to learn the materials very well in order to teach others. A great experience. I am too late to read this book. I think it's Ma'am Sama. It's the right time she's here. When she did her presentation, she said that, why am I too late to read this book? I should have read this book earlier. It's very informative because learning is lifelong learning, isn't it? It never ends. So never too late to read any books. First time to read the book, 7 Habits of Highly Effective People. Yes, this book was there since how many years? First time to go know more. So please, let's go back and know more about this book. And personally, me, listening to those lectures from our great speakers, what did I do? I was explaining to my son about the 7 habits. I made him to do a small lecture in his school about the 7 habits. So it means that I learned, it will never remain with me, it will go to the others. Learning by doing. It helped me to have the deeper understanding of the subject. I'm using, this is the most powerful statement, I'm using the language of 7 habits during my daily communication. Win-win solution. Put first thing first. Every day when I come to work, priority list. Put first thing first. I learned this from my lecturing. So if I can ask some of the speakers, I think Ms. Deborah is here, Ms. Sama, who else? Ms. Raquel. Many of the speakers are here. Deborah, if I will be asking you, how was your experience for being a speaker for a new topic, such as 7 habits of highly effective people?
Hello. Good morning. Honestly, I was one of the speakers who was asked if I have the knowledge about this book. And I said that I don't have, and I didn't read it at all. So the most beautiful thing about learning by doing, it is a generation friendly. As Ma'am Shaibi said, it's very easy to learn with the children and people at my age. And in the process, you don't know the topic. That means you have to exert an effort to know the topic, because you have to present it to people that are knowledgeable. And these people are not your staff. So the challenge is there. And I was able to explore the topic and learning takes place by being naturally inquisitive. I didn't understand. I just need to explore more. So you realize that these topics, you are actually doing it. That's the beauty of it. Like it was assigned to me about synergize. So a deeper meaning of synergy is not only a teamwork. So really, I have a great experience about this, and I'm excited about my staff learning this on bedside.
Thank you very much, Ms. Deborah.
Excuse me, Ma'am Shaibi, 1 minute more.
Yes, sir. Yes, Sasha. Yes. Sorry, 1 minute more. Okay, so this is my last slide. So thank you, Deborah, for sharing this great information. And all the speakers, they had the same experience. So in summary, active engagement facilitates deep learning. We learn best when we deeply engage with the material. Strategically aligned business can motivate and train their employees to bring together all the important elements of the business to achieve long-term company goals. And these are my references. I will end my presentation with a Chinese proverb. Tell me, I will forget. Show me, and I may remember. Involve me, I will understand. So involve your bedside team so that they will understand. Thank you very much.
Thank you, Ma'am Shaibi, for the great presentation. So it's gratifying to see that the hospitals and healthcare system are placing such importance on patient satisfaction. After all, it's really all about the patient experience and providing the safest care, best service, and high quality of care. Patients can forget the quality of clinical health care, but they cannot forget, and they can measure the quality of experience. So our presenter now, she is our director of the patient experience in Dr. Suleiman Faqih Hospital. She graduated from King Abdulaziz University with bachelor degree of food and nutrition in 2004. She also finished her master degree of healthcare administration in University of Scranton in USA. She has also certificates in types of customers, effective communication, patient experience, and she has also Lean Six Sigma Green Belt. So please welcome Ms. Sara Al-Rukhmani.
So, I used to speak loud in the middle. I think I need this. Don't worry. You can hear me now, right? All right. So, thank you for introducing me in this way. I really appreciate it. Thank you, Ms. Shaibi, for inviting me. It's a pleasure, actually, especially you know how much I love nurses. It's one of the things that bring me back to DSFH. It's the nurses. Yes. So, well, today we will be talking about language of caring. And what's language of caring? And why language of caring? But let me start first by asking you a very important question. If you heard that there is an outstanding physician, ENT physician, let's say, he is an amazing in his field. He is the best in his field. However, he lacks empathy, he lacks compassion, and he have a poor communication. Would you go to him? I want to see hands so I can see. Who would go to a perfect physician but has a lack of empathy? Who would? None, right? So it's by nature, caring should be our language. Should I? From the computer? Let me first, I think I skipped one. All right. I would love always to remind you about the patient experience mission in Faqih Care. So we sat together, leaders, patients, physicians, all of us, nurses, leaders, just to bring this definition to the floor, that patient experience mission is delivering a seamless, personalized experience to exceed expectation. Is it hard? It's not. It's very possible. By the language of caring, we can exceed the expectation. So the Department of Patient Experience, it talks about patient relations and service recovery, where we handle the complaints and we handle the most effective voice of the patients coming from social media and other sources just to satisfy the patient if they have the right. Patient experience services, where we have the patient experience on the floor to help the patients, to help the staff, to tell us where we can improve. The social services, where they also responsible for the DAMAs, AMAs, and neglect and social referrals from the physician on floor. Hospitality services, where we are working to let all our patients smell something good, hear something good, and see something good. So we are working to improve our experience through the hospitality services, through 5 senses. Our foundation, patient engagement, staff engagement, innovation and digitization, hospitality, and compassionate connected care, where we put the patient in the center of our care. And now we can start our real presentation by giving you my favorite quote for Dalai Lama. What his quote? Real care of the sick does not begin with costly procedures, but the simple gift of affection and love. Love. Remember these words. Affection and love. This is a real story from Daisy Award. She has made me laugh when I wanted to cry. She is exactly what you want in a nurse. She really cares, really listens, and acts on how the patient is feeling. Takes the time to explain what doctor said, show you how to sit so you are actually comfortable, and knows when you need some cheering up. I'm so lucky she is my nurse. It's very important to start by patient story. It's very touchable. When we see all these things in one person, it means a lot. This is what we are seeking to. This is what we want every person, every nurse, everyone to do. We always love to add some statistic to our emotional part, and this is a good question for you. Poor communication is the input of how many patient complaints? Do you know? Any guess? You were there? 80? Maybe. Good guess. Any guess? 75%, statistically proved. And I can just also prove it, as I'm the director for also the patient relations. We are receiving a lot of complaints just for miscommunication. We don't understand each other carefully. We don't listen carefully. We don't know what the patient's really looking for. Why language of caring? Patients always anxious. They are vulnerable. They come to you with less power. They don't have the power. They need just one thing from you. You know what is it? Reduce suffering. They are not looking for anything. They're just looking to be in a good hand and reduce their suffering. Humanizing healthcare. I'm so sorry to say that in the technology world nowadays, we are in a compassion crisis. We are really in the middle of compassion crisis. Yes, indeed. Where the physician start talking to the computers more than humans. Right or not? We are reaching there, right? So where is the humanization? Not only patients need compassionate care, also the staff, they need compassionate care. The leader's responsibility is to provide the compassion for their staff. We should be empathetic with our staff. The world in crisis, economies are unwinding, jobs are disappearing, and our spirit is being tested. Right? Everyone left something in his home, coming to another country, and left his home just to do his job. So we are suffering. We need to treat each other in a good way. We need it. Ms. Shaibi was talking about the 7 habits, right? And the fifth habit and the 7 highly effective people is seek first to understand, then to be understood, which is a very important. But when I read more about this, it's about not only communication, it's about listening. Stephen Covey was saying that there is 4 levels of listening. You know what is it? Ignoring, like not listening at all. Pretending. Like it's like you are pretending you are listening to the patients. Selective listening, where most of us try to do it, take our part and leave the part that we don't like. It's a human nature. But what we are encouraging everyone to do is attentive listening, which is the empathetic listening, is listening with your sense, with your body. Is when you show the patient that you are listening, show them that you are going to do something. So just active listening, paying attention and focusing energy on the words that are being said, not for the sake of just hearing. There is a study, which I liked also, in an academic medical center in Northeast in America. They implement the language of caring, okay, Plaintree actually, implement the language of caring into different era just to see the improvement of the nursing communication, overall rating, and likelihood to recommend by the patients. And you can see how statistically language of caring improve the communication. There is a study in Plaintree, which I really like the most, based on 6,000 focus groups, and they interviewed 50,000 patients and family caregivers across the continuum of care. What's their top concern was? The first concern, absence of caring attitude from providers. See, it matters. The second is dismissal and trivialization of patient's voice. So each time we receive a complaint, we said, ooh, it's a complaint. We should not deal the complaint. It's like it's something really not good for us. It's a treasure. There is someone telling you where you should then open an eye. And you need to fix this to improve. And definitely the last part is the lack of continuity of care. Let's add some statistic also to our emotional part, which is the language of caring. So I have learned that really numbers speak louder sometimes than emotions. I don't believe. But we should believe, because the more number we have, it's the most right things that we need to believe in. 66% of healthcare choice decisions are based on word of mouth. So when we sat together with my friends, they said, you know, Sarah, you have the best nurses in DSFH, or you have the best nurses in X hospitals. We said, yes, they are the best. The next lady said, well, you know what? I will book and see our experience in your hospital next time. This is how it works. We don't go and read. We just go and ask the others what's the best hospital to deliver our babies in. 96% of your unhappy customers do not complain to you. So we are probably losing those customers. They don't come and speak. 96% they don't come and tell you you are not good. Which is, for me, it's harder to gain those people. Very hard. Because I don't know where is their pain. 90% of your unhappy customers will not choose your organization the next time they need care. They are unhappy. Why they would come to you back? When customers are dissatisfied with the service, they tell 20 relatives and friends. 20. They keep saying, they are putting it in Google review. Each time we wake up on Google review, seeing who is saying something about our hospital. So yeah, they will spread this word. However, if they are satisfied, they only tell 5. It's unfair. So we need to work on this more than that. At the end, employee behavior toward customer is the most powerful marketing and customer satisfaction tool an organization has. So yes, you are our marketeer if you provide the good of caring. Why language of caring? To lead the health care industry. How many hospitals going to open next year, 2023? It's after 2 weeks. How many hospitals? How many hospitals? You know? 4. Do you think the patients will wait to fix our language of caring? They will leave us. Empower our patients. We want them to engage in their care. The more they engage, the more they feel comfortable with you, the more empowered, the better care they will have. We want our patients to cautiously trust us. We want them to pick us next time. Thus, we want to speak the language of caring. We want our patients to have a positive experience. Each time I talk about compassion, I like to express this spectrum of empathy. This spectrum has said that there is a big difference between pity, sympathy, empathy, and compassion. What's the difference? Well, when you feel pity and sympathy, when you see someone suffering, you will feel like, he's poor. It's in your mind. How poor he is. Oh my God, she has cancer. Oh, he is crippled. Oh, she doesn't have children.
Excuse me, Sarah.
Pity and empathy.
2 minutes more, ma'am.
All right, I will do my best. However, empathy is when you show the feeling with the patients. You walk the talk. So you are not only listening to them or showing how pity you are or sympathetic you are with them. No, you are listening to them like you are in their situation. However, compassion is you moved with them. You went to the right action. You took the right decision to improve what they were talking about. So empathy is the power of understanding and imaginatively entering into another person's feelings. This is the theoretical. We say it, put yourself on others' shoes. And guess what? Now, the leader will start picking the good employee based on the emotional intelligence. There is now a test called IQ and EQ. And you all know the IQ. And the EQ is the emotional intelligence. And emotional intelligence is the ability to comprehend how others feel and react, and to use this knowledge to make sound decisions and avoid or solve issues. This is a study by Daniel Goleman. He is the godfather for the emotional intelligence. He said there is 3 types of empathy. Cognitive empathy, that whereas we understand that the patient is suffering. It's just understanding. Emotional empathy, when you really feel the pain and the suffer of the patients, and you really want to help. Compassionate empathy, which is the desire to help and support. So the more effort you put, the more action you take to improve their experience, it's called compassionate. The empathy versus compassion, according to Schwartz Center, empathy refers to the ability to sense another's emotions and understanding their thoughts. However, compassion is caring concern for another's distress and suffering, coupled with what? Actions, actions, actions. Body language. What if I will come to you every morning, say, good morning? Did I say something wrong? No, it's a good morning. But what if I will say, good morning? There is a big difference? You can feel it? The slides explain that really body language matters. It's not only the words. It's even the gesture. It's even the smile. Show me the smile. Yes, yes, yes. Smile. We need it. We started 2 months ago a program called Thanks from Your Patients. I bet that most of our beloved nurses, they know about it. So whomever have a good comments about our nurses, we distribute this to everyone. I like seriously what they said about our nurses. And maybe my favorite when the patients specify the time. When he said, a Filipino nurse helped me provided a blanket when I felt cold on the night of October 13, 2022. See? They remember you. They remember all of you. Don't think that our patient, they don't care. Don't think. I would like to just leave you 2 minutes, please, with this video. I'm not sure if it's, from where I should.
Acts of kindness, acts of generosity is how simple it is to make people feel good. I was walking down the streets of New York City, and a guy walking in front of me, his backpack opened and a bunch of paper fell out on the street. I didn't think much of it. I bent down, I gathered up the papers, handed them back to him, and pointed out that his bag had opened. Now, in our bodies, there's a chemical called oxytocin. Oxytocin is responsible for all the warm and fuzzies, unicorns and rainbows. It's responsible for all the warm feelings and connectedness we have with each other. Friendship, love. Huge amounts of oxytocin surge through a woman's body as she gives birth. This is what is responsible for the mother-child bond. Oxytocin binds human beings. There are many ways to get oxytocin. One of them is acts of kindness and acts of generosity. It feels good when we do something nice for someone. It feels good when someone does something nice for us. On this particular day, I did something for someone with no expectation of anything in return. I got a little surge of oxytocin. I felt good. He turned to me and he said, "Thank you. It feels nice when someone does something for us with no expectation of anything in return." He felt good. I walked to the end of the street. I'm waiting to cross the street. And a total stranger who happened to be standing next to me said, "I saw what you did back there. That was really cool." As it turns out, witnessing an act of generosity releases oxytocin, and he felt good. And the best part about oxytocin is the more oxytocin we have in our bodies, the more generous we become. It is Mother Nature's way of trying desperately to get us to look after each other. I can guarantee you that that man who witnessed what I did something nice for somebody that day simply because he saw someone do something nice for somebody that day. So what if we commit to do something nice for someone with no expectation of anything in return? Imagine what happens at work. Imagine what happens at home. Imagine what happens with our friends. But it must be genuine.
It must be genuine. Remember this. So take-home message, going beyond professional boundaries can allow us to compassion. Be more humanist, improve communication, will reduce patient distress and anxiety. Body language matters. Remember that very well. Seeing the world the way other people see it allows us to understand how they feel. Helicopter view. This is what we want everyone to see this. Reduce suffering and definitely coordinate care. I would love just to end my presentation with this beloved quote. I liked it actually so much, and I believe in it. If you want others to be happy, practice compassion. If you want to be happy, practice compassion. Practice compassion. Trust me, you will feel good. And definitely, I will leave you with my best quote that people will forget what you did. What you said, sorry. People will forget what you did, but they will never, ever forget how you made them feel. All right? Any questions?
Thank you, Ms. Sarah, for the great presentation. Now the stage is open for our audience to ask questions for Ma'am Shaibi and Ms. Sarah.
يعطيك العافية. Amazing presentation, Sarah. My question here is, you're addressing an audience that has compassion in their genes. We were taught as nurses since the very early days on how to be compassionate, and nurses tend to be the most compassionate sort of members of the healthcare team. Yeah. How do you think that could transcend to other members of the healthcare team? How do you think that level of compassion can be? Is it something that people can be trained on? Is it a culture that we build as an organization or as a country or as a small house or a home? Or can we transform a certain culture to being a compassionate culture? And how can we do that, in your opinion?
Sure. Thank you, Mr. Mohammed, for asking this very good question. And actually, I used to believe that the compassion, it's yes within our genes, but it ends up it's not. It's the more you practice it, as you will become good at it. Seriously. I used to believe that the communication skills is not learnable. We cannot learn communication if it's not, we are not raised having the skills, but not. It's not. It's how you practice. If you practice every day to come in the morning smiling, it matters, and you will smile. So maybe the best thing is to train our staff, is to coach our staff, is to counsel our staff, and is to show the staff, all the staff, what's the patient saying about you. Mr. Adil from Prasgani, he said a very, very valid point, that we always have the numbers, which is either black and white, but we have always the comments, which is the colorful for this black and white. The comments will tell us what we are doing and how we should do it. So why we are not listening to this? So listening to others, say that we are open for any criticism. I think we are open to learn, and there is always opportunities for improvement. Thank you.
I think we have a question from the back.
This question is for Ma'am Shaibi. Ma'am, engaging our staff is one of the challenges that we are facing today. So what are the strategies or tips that you can impart to us in order to handle these circumstances?
Thank you, Lemika, for the question. Everybody got a talent. Everybody got a talent. So it's very important that open their, showcase their talent. So tell them that you have a talent, come up, let's try it. I'm here to support you as a clinical resource nurse, as a professional development chairperson, as an educator. So when the staff know that there is somebody to back up us, we have seen the video earlier, there is somebody to be as a backbone when you are about to fall down, they will remember that it's okay, I can do that. So encouraging staff that they have a talent, just try it, they will do it. So those staff who are trying to be backup from any assignments, do this lecture, now it's just a matter of giving them an encouragement and motivation. So I'm sure that there will be a percentage of staff who doesn't like to do that, but still there are multiple ways to encourage them. Let that person see other people how they are doing it, then they will be motivated, because we are teaching adults. Adult learners will like to do it when the topic is more relevant to them. So don't assign topics which are not relevant to them. If it's relevant to them, they will be more participating in the activities. I hope I answered your question. Thank you.
Good afternoon. This question is for Miss Sarah. From Sarah. Actually, we are mostly focusing on communication, the language of caring. I would like to ask, actually, for your opinion, this is not mainly a question. How can we ripple, because we're focusing, we have workshops for communication. So how can we ripple this message that we also understand the side of the staff, as I believe that they are also our customers. They are part of the organization. So I know, I'm not sure if everyone agrees that a satisfied staff will also have a satisfied patient. So how can we deliver this message to the rest of the staff, not just for the nurses, but for the rest of the organization? Thank you.
See, you gain now the pleasure from everyone asking this question. And I truly believe that listening to our staff before our patients, start with listening empathetically. Start by being compassionate with them. If they are telling you that I cannot sit on this chair, it will hurt my back, change it for them. If they will tell you, I have a problem with this patient, call patient experience to solve the problem for her. Being empathetic with them. Start with the staff even. And by the way, this is what I used to do. When I do a training, don't think that I always just talk. I listen to the staff. I see what they are, what they concerns, what they need us to improve. I listen to them, then I tell them what I want for them. So after fixing what they are looking and that they are expecting from the higher management, then they can smile to the patient, and they can be empathetic with the patient, and they can be more compassionate with the patient. Without listening to them, we cannot force them to do the same thing. All right? Thank you.
Thank you, Ms. Sarah. And Ms. Sarah. So for the last questions, we have Mr. Muhammad Turki.
Yes, Ms. Sandra. I have one question. It's really an observation I have experienced during our clinical at the hospital. For example, if there is any complaint or comment from the customers at the hospital, when they are coming to Mr. X, for example, they are really the patient or the relative, they are listening from him. But if they are coming to Mr. Y, for example, they are not listening to them or they are not accepting them. So from your side, we need the major principles. You are recommend all the staff here at the hospital to follow to meet the patient experience and to achieve our person-centered care.
Your question is regarding how we can improve the patient experience in our hospital. Again, it's the same thing as to listen to the staff. After fixing their problems, after listening to them, if we are not satisfying our staff, we cannot improve the patient experience. And by the way, do you remember our 5 foundations? When I said we have 5 foundations, one of them, they said, one of our pillars is staff engagement. Why? Many of people tell me, Sarah, you are patient experience, you are not staff experience. Well, no. I believe strongly that we can start improving patient experience from the staff engagement. Yes. Thank you.
Thank you very much for our great speakers. Now it gives me honor to call Madam Shaibi and Miss Sarah to the stage.
One more question, sorry. Yes, the last.
10 riyals.
Okay. Ms. Sarah, thank you very much for the great presentation. I actually love your energy and your smile. You said that we are happy to receive I don't want to say bad comments, negative comments from the customers. What if, or are you receiving aggressive comment for the staff, and what your rule if you receive aggressive comments about staff personality, background, her attitude, not her work? Are you doing something for this?
That's a very good question. Yes, definitely. We do counseling. I bring him, I need to listen from her. Maybe no, she has the right, not the patient. Many of people, I'm telling you, they told us, you are a patient experience. Don't pay attention that much to the staff. No, we want to improve our staff morale so they can give. And again, when I received a complaint, we don't punish at the same time. We first listen. And even the leader, we ask them, listen to them. Maybe there is a valid point why they did so. So if we hear from both sides, then we decide, is it really a patient side or is it a staff side? And by the way, we do take really a good action when it's a patient against staff. There were a violence or a bad or abuse from our patients. We don't accept this. And I think most of the staff know this about us as a patient experience. If there is something went wrong, no. We will tell the patients that this is not unacceptable. And if this will be repeated for 3 times or more with another staff, we might close his file. That's that simple.
Thank you.
All right.
Thank you very much. Now it's a time for just to say thank you for all our speakers and moderators. So can I ask Madam Shaibi, Ms. Sarah, Aisha and Ira, would you please come here to the stage? lectures. It gives me honor to introduce our moderator, Ms. Cora and Ms. Rachel, to moderate the coming session and to present or to introduce the first presenter. Cora, floor is yours.
Thank you, Ma'am. Okay, good afternoon, everyone. So let's proceed. How does understanding culture help retain nurses? Allow me to introduce our next presenter. She is our Acting Chief Nursing Officer at Dr. Sulaiman Faqih Hospital, a graduate of nursing in DSFH, who demonstrate knowledge and transformational leadership, skills, and has a vision, a strategic and quality plans in leading nursing services. With a total of 14 years of nursing career, with a vast experience in critical care area, has been a nurse manager and a critical care service line director, a member of the electronic medical record development team, one of the team who introduces continuous renal replacement therapy, a member renal transplant program, and an extracorporeal membrane oxygenation program. Let's all welcome our Acting Chief Nursing Officer, Kadra Omar.
Good afternoon. I hope you enjoy your lunch. My topic is about painful area that we come across as a nursing, in a nursing career, which is retaining nurses in your unit. I will tell you as a nurse manager and as a director, and now as an acting chief nursing officer, the pain is differ because when you are acting chief nursing officer, actually you are responsible for the whole department's retention rate. But when it comes to the level, to the unit level, what matters is to have experienced, well-educated, skilled nurse that you build. So how it is painful losing those caliber after developing and motivating them and building them their skills. So my topic will be about how we develop a culture of retention for nurses. So my question is first, who do you think is responsible in retaining nurses? Any volunteer? HR? So one attendee said HR. Any other opinion? Who do you think is responsible to retain nurses? Their colleagues. Organizational level. So I'll just tell a short story that I came across. I used to have one nurse named Amelia. Amelia, she takes her position. She was new when she joined me, new graduate, maybe has 1 year experience. She was a very motivational nurse. She was very skillful, and being with me or in the unit was, she grew a lot, she learned a lot. She learned everything in the unit. She was a member in developing policies. She was a hard worker. Her colleagues loved her. And one day she decided to go. And that was painful because you build someone, you want that person to stay with you. So again, nobody knows why she go until she said, I'm going. And all her colleagues thought that she's fine. She wants to stay with me. But in fact, she was planning to leave us long way ago. So when it comes to recruitment, if you want to recruit nurses, it's best to retain. Why? It's cost effective. Returning nurses is cost effective. And it's very important to develop an area where the workplace attracts quality nurses, and employees and nurses need to prioritize the retention. No matter how often the incentive that it was given to any nurse, it's very important to build the capacity within the unit itself in order to return nurses. Sorry. Okay. So why do you think it's very important to return nurses? And what's the benefit from retaining nurses? So first, by returning nurses, employee morale will improve. You just imagine, if you lose 3 nurses, this will affect the remaining nurses. Why? They will work hard extra hours. They will lose their off. They will lose their, rest days. So they will work extra hours. They will accommodate more patients. That will affect their morals. Also, why it's very important to return nurses, because if you return nurses, more nurses will stay. Sometimes you will find the unit, 1 nurse resign, in return to that, 2 more nurses will resign. Why? Because the other nurses are thinking, if they leave this unit, then the work will fall on us, all of us. So it's better to leave rather than receiving an extra hour or working extra shifts. So why it's also very important, what's the benefit of retention? In retention, if you return nurses, you will decrease the turnover cost. In HR, it's very important to count how much we spend on bringing new nurses. Imagine the visa, the medical checkup, the hiring, the airplane ticket. All that is considered a hiring cost. So if you return nurses and you invest it in their payment, this will decrease your cost. Also, if nurses resign, that will increase the labor cost. If you are giving to any nurse overtime, you are paying her how much? 1.5. When you regular hours, you will pay 1 hour only. So 1.5 versus 1 hour. So by losing more staff, the labor cost will increase. Returning nurses will improve patient satisfaction. Returning member improve productivity, quality in the patient care. And there's old saying is, if you keep your nurse happy, then your patient is happy. It's very important. It's not vice versa. Make your nurses happy, then patient will become happy. Retention improve the quality of care. There's a study says increased nursing turnover, decrease patient care capacity as well as patient safety. Returning nurses reduce error, improve continuity of care, and increase survival rates. Because returning nurses mean you are keeping an experienced nurses. Because sometimes we lose an experienced nurse, but we get new nurse. So the chances to have error, it's high. Supportive work environment improved are positively correlated with quality patient care, while supportive work environment are negatively associated with burnout. So what is the factors that affect the retention? Nursing competency is one factor. Teamwork, it's another factor. Work engagement and fulfillment is a factor. Meaningful managerial support for nursing is also a factor of retention. Physician-nurse collaboration is one important factor because this is who you are working with in your unit. Nurses' participation in decision-making, autonomy, when it says, it's a very important factor. When we said work engagement, what we are talking about is about engaged workers. They are energetic, enthusiastic, and it's very important to talk about the relationship during the work. When we say this is a work in an environment that has a work engagement, we are talking about the relationship also in the work, in a relationship with fellow nurses, nurses to nurse, relationship with physician, and your relationship with your manager, and also teamwork among working environment, and the recognition for your employee. In culture of retention are influenced by 3 factors: leadership, meaningful work, and retention focus. So when we say meaningful work is employee-directed care. If you see, when we are designing a care plan for any patient, we are designing because considering the background, the ethnicity, the preferences, and everything. So it's very important also to have an employee-directed care. You need to see what's the background of your nurses, what's their preferences, how they like to receive their training, for example. So it's very important to design an employee-directed care. Also, autonomy in decision-making. If you ask any nurse why you become a nurse, she will tell you, I want to help people. So when helping people is autonomous decision. So organizations should help nurses in achieving that purpose. Appropriate workload and patient interaction. It's very important that nurses, when we say meaningful work, is that nurses have appropriate workload, not overloaded, where they cannot provide and they cannot give time for patient-to-patient interaction, or time for patient to for nurse to relative interaction. Also, a variety of work. You will find new nurse suddenly she don't want to work anymore. She's bored, because she's doing the same thing every day. Every day she's coming, taking care of a patient. There's no alternatives. There's no options. Much options. So it's very important to think of the variety of work that is provided. Valued as a colleague, as a person, and a part of the team. It's a way of improving the engagement in the work. Also, resource and support. It's very important when a manager or a colleague or a senior team are in the unit is to provide the support and the resources. I'm just quoting, if for example, in a unit, when you are managing a patient, but you have to run for all the resources that you need. It's tiring, right? You feel like, yes, you work, but it was very toxic. It's very important that the staff, you provide the resource and the staff will utilize it. But without it, don't let the staff look for the resources and search for it, when it's very important to have it ready to use. Opportunity to learn and new knowledge. It's a way of retaining nurses, providing the learning opportunity. Feedback, constant feedback. Every day our staff are coming to the duty. They're doing great job by keeping the patient safe. It's very important to give the feedback. Positive feedback. Also, if a negative feedback is provided, you need to mention the positive and the improvement, where to improve. So how you give the feedback also, it's very important. Leadership. Leadership, it's a very important factor that affects retention. So leadership, they need to be a champion for change and open to new idea. It's not like I am the leader, I am the manager, this is how it needs to be done, everybody must follow. So your staff, you'll be surprised if you listen to your staff, the amount of idea that can come from their brain. So it's very important as a leader, you encourage this idea. Inspire a shared vision of organizational direction. You are representing the organization when you are leading a unit or leading a department. So it's very important that you show the vision in your act. Motivate and recognize. Some people think about the motivation and the recognition as give certification, give party. Simple thank you to the staff when they do good at the same time that they do perform well. It's very important. It's very meaningful. Leaders should model behavior that reflect organizational value. You cannot say we need to talk about patient experience when you don't care about the patient experience. You cannot say to improve, for example, hospital-acquired infection when you don't wash your hand, for example. So it's very important that you represent the organizational value. Incorporate recruitment and retention together. when you are recruiting, think while you are recruiting how to return those staff. And the retaining staff can start from the time that you are recruiting the staff during your interview. So unit should, first, who do you think, again, that the retention, who's responsible for the retention? I just want to announce it to you, retention is the responsibility of everyone working in the unit and in the organization. Colleague, as a colleague, you are responsible for a retention, for your colleague retention. As a manager, you are responsible to retain your staff. As a physician, you are responsible to return staff. Any ancillary department, it's very, role is important in returning staff. So retention focus. When I say retention focus is to incorporate the retention strategies within the daily work, So say thank you for job well done, reinforce desired behavior. It's very important to pause, for example, when you are working in a very busy unit, to pause for a moment and recognize one staff, call everybody and mention the positive act that was done from this staff. This will encourage her to do better also, more and more, and also will encourage other staff that they are working in an organization where they are thanked. Create an emphasis and focus on retention. It's a very important. Build self-esteem, celebrate success together and individually. Mentor, it's coach and groom. So if one staff is doing good or not performing well, you need to coach and mentor. And also, if the staff need grooming and adjustment, also that needs to be done in a very appropriate way. So retention is the best recruitment strategy. It's not about when the staff leave, then this is the time you will think about the retention. It's not about just thinking how to recruit new nurses. It's about recruiting, yes, and also returning those nurses. So retention, as I mentioned, is the best recruitment strategy. Positive work environment. When we say positive work environment, it's about interact in a positive manner. Verbally encourage colleagues. Another option is to send email. It's very touchy if you send email to your staff and thank her for a job well done. One strategy also is, instead of giving goodbye to a party for the staff who are leaving, make a party for the staff who join. How many of us do that? It's very important that you celebrate the staff that came to you. Show them that they are valued, you are happy that they join. Celebrate their joining. That will impact a lot in their moral. Another initiative for positive work environment is to look for positive behavior, talk about them as soon as possible. So your staff did great today, talk about it today. Don't forget, don't talk about it next week. Next week it will be meaningless. The same time, as soon as possible, embrace the positive acts and talk about it. That will encourage and praise 5 every day. The goal is to acknowledge 5 positive behavior every day. Just write 5 positive behavior that you want to acknowledge every day. It will be meaningful. Both motivational and inspirational quotes in your unit that give a push spirit to the employee. Empower your colleague. Lead by example. As a unit leader, as I mentioned, groom other staff to be leaders. It's not like I know everything. Teach others to be just like you. If you are good, then and your staff are not performing well, it doesn't make you good. It doesn't make any leader good leader if your staff are weak. So it's very important to groom your staff to be just like you or better than you even. Provide we can do it attitude. Sometimes you'll feel like the staff are down, they need motivation. If you are back at the back at that time and they do not feel the support, then their moral will be affected. So be the leader who say, yes, we can do it, we go through this before, we can do it again, and we can perform well, even if there is an, if the performance went down or your numbers or indicators go down. It's very important, instead of blaming or blaming the negative indicator, is to motivate and say, yes, we do it before, we did it for 1 year, we can do it again. Create an atmosphere of mutual respect and trust. Communicate all information with all teams. Sometimes leaders identify, choose the staff who are active with them, and they give all the information to one staff. So when that leader or that staff are out, so the staff don't know anything. And that's really affect the staff moral. When someone comes from outside and they ask about some information and nobody knows, that will affect the moral of the staff. So it's very important to communicate all information to everyone. And I know one nurse manager that the unit, equipment, any communication, any patient issues is communicated from the manager to the general aide, then everybody can answer if any question is asked. Nurse-directed care, as I mentioned, establish different council, patient council, retention council. In a magnet language, it's a shared governance. So shared governance, in a way, is a way of empowering the nurses and involving them in the decision making, and that's really motivate the staff to give a brilliant idea and have brilliant initiative. Be flexible. As a manager or as a leader, it's very important to ensure that you are doing flexible schedule. Actually, having a person-centered care council or resource utilization council, and I'm sure many managers here tried this, and whoever didn't try, I encourage you to try it, is they give the schedule to the bedside nurses. Because bedside nurses can talk to each other easily. Maybe the nurse will be afraid or threatened to talk to the manager or to offer her schedule or to negotiate her schedule. But with bedside to bedside, it's very easy to negotiate a schedule. And bedside know each other more than the manager knowing the staff. So if you give it to them, first of all, you empower them, and you give them the autonomy in deciding on their schedule. One of the questions that asked in the NDNQI for nurses are insatisfaction is how much you are involved in your schedule. If you do that, that part will improve in your RN survey. Also, engage staff to make a written request ahead of time. It's very important to communicate this, especially in an area where you don't have staff. So you have to schedule. You cannot give all the requests together. You cannot satisfy everybody, but I'm sure there is an important occasion that the staff want to request. So encourage the staff, announce, communicate it very well that the requisition is open and it will be closed, for example, bottom line, provide them appropriate information to everyone to access. It's very important to give meaningful continuous education. One of the things that retain nurses is that accessibility to the education. Staff want to grow. Yes, we study in the college 4 years, 5 years, but without learning more, you cannot learn. And it's very important to learn what is the updated knowledge and the skills. Participating in in-service education, it's a nice initiative. And I can find that some units have their own educational schedule where nurses are giving the education itself. Attend seminar together outside the organization, self-assess competencies, and attend needed in-service education. Give access to that. Also, provide a team building seminar. It's very important. Team building seminar means like look for a workshop where there is a team building seminar, and that will improve the communication among the staff. Staff integration begin the retention effort during the hiring, address social needs during the hiring itself. Sometimes some hospitals put like a banner in the interview sessions about how it's important to have you here, how it's important to retain you once you join. So at the hiring process, it's very important to start your retention process. Address social need. I found it very important and very effective when you address the social need of your staff. Your staff will I'm sure they will praise you and they will love the area that they work in if you think about their social needs. It's very nice to ask your new staff to join you for a lunch. I remember last week there was one new staff who joined, and the manager showed in 2 minutes to take her from the nursing office, and she was very happy in joining her. Immediately she took her for a lunch and she gave her a coffee, and at the same time, I'm sure they're here, her husband joined also another unit. So they were comparing, oh, I'm happy, I eat my lunch, I drink my coffee, and it's very important to feel your staff welcomed when you are with them, especially when they are new. Value your colleagues.
Excuse me, 5 minutes more.
Sure. Use a platinum role. The platinum role is if always the golden role is what? Treat everyone the way you want to be treated, right? But platinum role is treat everyone how they want to be treated. It's very important because there's personal preferences. Be visible to them as a manager. Call, it's very important. If you give a call when you are off, how's everything? Do you need anything? That is very meaningful. Leave surprise for staff in the staff lockers. Place suggestion box. This is one of the strategies some units try, and they receive a lot of suggestion. Schedule some meeting where you say to the staff, what's in your mind? And then the staff will talk. Instead of having fixed agenda that you need about education, about and everything, it's very important to ask the staff sometimes what is in their mind so they can talk freely. Hold colleague accountable and discuss issues. It's very important to address that. Sometimes you will find that one of the staff is doing a lot of violation and everybody is not comfortable, but the leaders intend to ignore that. It's very important to hold those colleague accountable. Address issues with physician and any other department that affect your staff retention. It's very important. If the staff has a problem with certain physician, address that immediately. It's very important. Get personal, hold monthly birthday, give personalized message to the staff. Throw party for leaving staff, keep in touch. They may come back. And I have staff who came back after they resigned. Recognize staff for job well done, send thank you notes, suggest to physician to compliment the staff. That will shows that it's a healthy unit. Food, it's always something to celebrate around. And recognition, as I mentioned, display board for the staff of the month, nominate, recognize your staff through formal recognition or informal recognition, like Daisy Awards is a very formal recognition. Place a shout out board, right. I can see sometimes the units they send in the group, in their WhatsApp group, thank you for doing this and this and this and this and this. That's very important. It's like shout out, but it's online. Celebrate, as I mentioned, holidays in meaningful way. Schedule fun time out of the work. I know a nurse manager who schedule fun time with her staff. They are different nationality, so she take the Indian, for example, nationality to some place, and then Arab, and then Filipino, and they are all enjoying together, and they fix it together, their schedule, so everybody can join. Group requiring a special retention effort. New graduates, the highest rate in our nursing team now are the new graduate. And last year we received 20. This year we received 40 nurses, and then we are going to receive 40 nurses. Another 60 nurses are coming. It's very important to put strategic to retain them by providing transitional support through orientation, internship, residency program, preceptor, mentors, and close assessment of mentoring as they are coming from the academia to the practice. That's, I conclude my session. Thank you so much. And if you have any questions, go ahead.
Thank you, Ma'am Kadra, for that inspiring talk. So may we have any questions from the audience? Sir Mohammed.
Very, very nice presentation. And it's extremely helpful. I really like the tips. I think everybody can learn from those, especially the nurse managers, middle managers of the unit. One thing I wanted to ask you about to see if I can compare of what we are having in UAE and what you guys are having here. One of the main things that nurses don't like at all is pull-outs and having to be pulled from one unit to the other. And they verbalize that concern. They say, I don't mind working double shift in my unit, but I just don't want to go to another unit. Have you adopted a certain strategy at the SFH that can support nurses when they are pulled out? Is there a plan for that or something that you have done?
I'm sure. First of all, me personally, I used to enjoy pull-out. I will change environment in pull-out. But yes, I can notice that many nurses don't like pull-out. But the problem, the question is to ask here, why nurses don't like pull-out? Because sometimes if you pull out nurses and you did not provide them the support, they will hate to go back to that unit. So a strategy to solve this problem, first of all, engage nursing in pull-out. I believe everything, if you pre-plan, it will be successful in the implementation. So put in your policies, for example, that this is required because of so and so. Especially in a hospital like our hospital, it's a very busy hospital. Nurses have to be pulled from one place to another place. It's not by pulling nurses, by the way. Sometimes we brought different specialty to those nurses. For example, in an area where nurses are taking care of only OB-GYN, we admit pediatric. For example, in surgery unit, we admit pediatric. This is the need of the hospital. I cannot say that I will not admit the patient because my nurses don't like to be pulled. So it's very important to establish a policy of where we pull out nurses. And identify required list for example, where you will pull out when. So where I will pull out a pediatric nurse, for example, is it a different, same specialty or same service? It's unfair to pull, for example, OR nurse to critical care area and ask her to take 2 patients. So same specialty pull out that will help in easing the stress. Another point is we do primary care in our hospital. To make it effective, when you have pull out, give them a functional. So instead of taking, for example, full patient, in a way so that she will not feel like she's doing something very that she cannot adopt with. Give her primary function. For example, check the vital signs. That's functional functional model. So it's learning. Again, every unit every unit or every experience is different from others, but having clear policies, clear overflow policy, identify the competencies that it is needed, it's very important.
Thank you for that. I believe that's one of the things that I think also should be focused on, honestly, in any organization. It's the third cause of resignation in the United States is the cross-training. It's not about only planning it, in my opinion. Planning is nice, and we need to plan it. We all have those lists that has which nurse can be, have been cross-trained in which department we can pull out. It's also about the attitude of the nurses and the attitude of the team who is there and the assignment that is given to that staff.
Yes.
Many times, many instances I've discovered that whenever there's a new member of the team coming in from another unit, they give him the heavy assignment.
The heavy assignment,
or they
yes.
give her the heavy assignment.
Or the patient that no one wants to take.
Exactly. Or the patient that they don't want to take. So looking at the assignment and overseeing the assignment by the manager or the supervisor, making sure that they are welcome. When I round and I talk to nurses, when I see a certain nurse being pulled out, the first thing I ask, have they provided you a cup of coffee?
Yes.
This is the first thing I ask.
Yes.
And then the rest of the nurses get surprised. Should we provide? Yes, you should. And I always tell them, if you have a visitor in your house, what do? They say we take care of him or her, we put him in the comfortable chair, we try to take care of them. I told them exactly the same. You need to be to give. I like the idea of having a policy. I think that helps a lot. We have those practices, but sometimes we didn't really document them in a policy. I believe having it in a policy and spreading it around is a good idea as well. So thank you.
Thank you.
So, Kadra, if I will just add what Sir said. Sir, actually last week we have revised our cross-training policy. Also we included those nurses were pulling out from one unit to another. They need to receive a certificate of appreciation. So anytime when a nurse is pulling out from one unit to another, she should receive a recognition. Not only that, during Nurses Week celebration, the mostly pulled out staff need to be recognized with like a financial certificate, trophy, everything, because this is their willingness to help the next unit. So it's not mandatory from her side, but she has the willingness to help. Also, many nurses, they can maybe they are planning to go to another country, having a different experience, having two experiences at the same time. They also can request, can I be cross-trained to this unit? So it's our pleasure to give you training for those unit so that it can be added to your CV when you leave this organization that you have experience in this unit and that unit. So this is also possible. But as Kadra said, we will not be able to totally exclude the pull-out because our hospital is, how busy it is. But we can do a lot of strategies to make you, how to make you happy. When the new staff or the pull-out staff come to the unit, welcome them. Not a punishment, it's an added help. So we just need to take care of each other because one day I will be in her shoes. So this we need to think and just to handle together. Thank you.
Thank you.
One more quick comment. The topic is extremely interesting. I really like it. And I don't know if you face that as well in the SFH, because I face that on day-to-day sometimes in FUH, on maybe week-to-week, if I may say. Somehow nurses don't come forward. You just see the resignation on the system, or you just see the resignation on the table.
Yes.
Yeah. They are silent about it. They don't talk. They're very good with their friends. They're very good with their colleagues. They have the best relationship with their nurse manager, but then suddenly the resignation is there. And then I make it a habit to see every person who resigns, every single person who resigns. I bring them to my office and I tell them why. Why did you resign? Talk to me about it. And then after a lot of pulling and pushing, they start talking about some things here and there. But most of the things are not really related to the work environment. You would find different reasons for that. But my question here is, how are you encouraging the nurses to come forward before resigning? And do we have a system where we are studying our exit interviews and people who are leaving, what messages are they passing through? And are we putting some actions to improve those?
As I mentioned earlier, in every unit, team think that retaining one staff is the responsibility of the nurse manager. Yes, sometimes nurse manager don't have the accessibility to all the staff all the time, but colleagues have, physicians have, another unit member has this accessibility, and they talk freely. As a leader, if your staff are not talking to you, it's very important to question that. Ask yourself, why my staff are intimidated to come forward and be friendly, talk to me. One of the sessions that we started here in Faqih is open hour. Open hour where everybody can talk to the CNO, addressing what is their issue. And for example, in my new office, it's very important to have open hour when some staff is coming. Some staff, even for the open hour, they don't come thinking that other colleague will see them or their leaders will see them. So I scheduled the open hour in different area, in different meeting area where they can meet me freely and no one can witness that they even meet me. So how to encourage the staff is get closer. I think it's for the CNO, it's very difficult to see the unit, every staff, every time. But also as CNO, even you can see. One of the things that I do whenever I'm rounding is that I ask staff randomly, are you happy? Do you want to tell me anything? How can I improve your
But let me just
environment?
clarify something. It's not about the CNO visibility. What I meant is the behavior of really the behavior of nurses.
Yeah.
I've seen it in 6 different organizations or 7 different organizations, including many of which are in UAE as well, where nurses don't talk about them intending to resign.
Yes.
This is what I mean. Although you do everything, you round, you talk, you sing, you dance, you do everything, but then there's the intention to resign is not there until the resignation. Have you experienced that? Or?
As if someone resign and I was shocked that they resign, you mean?
Exactly the story that you have put in the beginning of
okay. Yeah, what I am saying, have I experienced this? Yes, of course, I experienced and stuff. I was able to convince, actually. I thought that she's very happy, and suddenly she said, no, I can't come. I can't stay. I will resign. I experienced this lately, actually. One of the nurses in ICU, very active nurse, very committed, but she said, I cannot take it anymore. And when I analyzed this, I find out that because she's too good, she was giving a lot of responsibility. You know, sometimes we overwhelm our staff because they are too good. So it's very important also to think in this way or minimize the load for those staff. Think that they may not be able to take this as long, or maybe they don't want, or maybe they want to take risk, or maybe they want sharing. They want other person who can share the responsibility with them. So that's my story.
We have a question from the audience. From Kadra, question from.
Kadra, good afternoon. This is Pauline. Actually, this is not a question, but I'm sure other staff will give also comments and suggestions or will agree with me. Let's say, for example, regarding the pull-out. Most of the time in MCH, delivery room is sending pull-outs to other areas aside from MCH. And as a unit manager, the thing that I usually face is resistance, of course. What I have noticed is staff are obliged to follow because for them it's their responsibility, even if they are resisting. But what I can ask also we can encourage help with each other from other units, regardless if we came from MCH, medical, surgical, or others. But the welcoming attitude, of course, of other units to those staff who came in to help, usually the words or the what do you call this one, phrases that I can get from the staff is that, Ate, we are the one helping, but why it seems like we are the one struggling. And I don't speak about staffing only. I think as a leader, I am also calling out for all the leaders here to be very open. And let's not, take comments and suggestions from other staff or our staff in order to deliver a good quality also of leading our unit and leading all our staff. Because for me, we are working in one organization, not in one unit only. So we should be very flexible, we should be very accepting, and the mindset that we bound to set to our staff and our colleague must be very clear. That we are working as a team and we are moving as a one body, not a one unit or one system only. And I think one of the reasons why staff are leaving, I think it's not enough for us to recognize them only. I think we need also to, if it's possible, if we can have also some programs wherein we can give financial supports to our staff who are always being pulled out, or because we already have a lot of strategies in retaining our staff, and all that you have presented, Ma'am Kadra, are very good strategies, actually. Very good strategies. But let's accept the reality that most of our staff here are expatriates, and the reason for us leaving our home is to get more financial support from the organization where we are working with. So I hope some of the staff here will agree with me that yes, we are so thankful that we are being recognized for our good deeds, and I'm sure that most of our staff are doing their best, not because of the recognition, but because they love what they are doing and that this is their passion to be a nurse and to do what they are doing. So I hope if you can suggest, we can improve as your leaders here. If you suggest something that could improve our way of leading also, it would be great. And I think, Ma'am Kadra, that is just a suggestion or comment from what you have presented.
Thank you. Thank you so much.
Thank you. Any more questions?
She should run for elections.
Any more last question from the audience? So thank you, Sir Mohammed. Thank you, Ms. Pauline. Thank you, Ma'am Kadra, for such an interesting topic. Okay, let's move. Unsafe medication practices and medication errors are one of the leading causes of injury and avoidable harm in healthcare systems across the world. So let's all welcome our multidisciplinary team speakers. He is, his designation is, he is implementation manager, Master of Science in IT, more than 2 years experience with Faqih Group, and overall 20 years of experience in hospital information system. Played key role to achieve HIM 6, HIM 7, SIBAHI, and JCI accreditations. One of his projects is the ASASI multi-site implementation. He is also one of the National Platform for Health and Insurance Exchange Services Integration, and Pharmacy Logistic Integration, and Laboratory Automation. Let's all welcome Mr. Munil Koniel. Second, she is an experienced pharmacist with demonstrated history of working in hospital and healthcare industry. Ms. Marwa has worked across multiple organizations in both governmental and private sectors, dealing with many companies specialized in the field of pharmacy medication management smart solutions. She has built great managerial skills and a vast knowledge in the field of general pharmacy, progressive medicine, and pharmacy automation and informatics, making them top skills in many professional environments. Ms. Marwa began her career as a pharmacist, and her portfolio included a pharmacy unit manager at Jeddah Kidney Center, KFGH for over 15 years, and after that, she became a pharmacy automation admin at King Fahad General Hospital, and finally leading pharmacy automation unit at Dr. Suleiman Faqih. So let's all welcome Dr. Marwa Awad and our very own Director of Magnet and Professional Development, Ms. Shaibi Joseph. Please come and stay.
So good afternoon, ladies and gentlemen. Again, I am back with my great team, IT and pharmacy. So today, we will be discussing about closed-loop administration to improve patient safety, a multidisciplinary approach. So in healthcare industry, it's continuously, like every day you can hear about misidentification, treatment error, medication error. Why? Because lot of human interaction is interfering in the healthcare. So I just want to post a problem here, not a problem, problems. Many reported OVRs of inpatients had cases of misidentification or medication error, including wrong labeling and wrong dose of medications. Wrong patients were given medications. During Q3 2021, almost 71% of the total OVRs or medication errors was related to near misses. 14% of OVRs were related to mislabeling of laboratory specimen during the month of October 2021. Simply because lot of human interaction for identifying the patients, printing barcode labels, labeling medications, dispensing medication, and medication administration.
Last 5 years, you can see technology is improving a lot. And if you compare technology in past 5 years and current technology, there are huge difference. In our hospital, recently we have implemented closed loop administration. The world where technology is immensely improved and innovated, it is timely to adapt technology to address and focus on accurate patient identification using closed loop technology in collaboration with multidisciplinary team including nursing, pharmacy, IT, medical informatics, supply chain, blood bank, and laboratory. The use of barcode scanning system reduces patient harm through proper patient identification, mislabeled specimens and samples that can harm patients with the same impact as misidentification.
And to serve our patients better and to be always more relevant in their lives, our main objectives from this project to reduce administration-related risk and errors and to ensure patient safety. Also to ensure all patient rights, right patient, right medication, right dose, right time, and right route. To increase patient identity confirmation with multiple identifiers before any medical procedures. Also to achieve connectivity and reporting from the point of prescription to the bedside medication administration. And finally, to improve adherence and compliance to hospital policy and procedures.
So if I will ask a question to the audience, what is the impact, what is the problem or what are the damages it can cause if there is a medication error or a treatment error or a procedure error? Yes? Medical complication, thank you very much, Dina. Legal issues, thank you very much, okay? Life-threatening, thank you very much. If there is a medication error was caused, admission to pediatric ICU, adult ICU, extended length of stay in the hospital, that financial burden to the hospital because those complications may not be covered by the insurance companies. So the damage can be vary from financial to physical, irreversible damage, and sometimes to the extent that we can lose life. Patient can die just because that treatment error, medication error, or procedure error.
These are the area we have implemented closed loop administration in our hospital. First, medication administration. Dr. Marwa will explain in detail about PICSes. Blood and blood product administration, human milk administration, and sample collection. These are the pre-implementation steps before implementing closed loop administration. Ordering use drug generic name, like our physicians are using generic name to order medication. Pharmacy verification process from pharmacy panel, like our pharmacists should verify our physician orders. Ability to read the QR code and GTN code. Our technology and technique should be read QR code and GTN codes. Alert for 5 rights. I think you all are familiar with 5 rights, right? I don't want to explain that. Integration between HIS and PICSes. It was a big challenge integrating medical equipment. I mean, especially PICSes with Yasashi. Barcode label for unit dose and medication. Availability of WOW and barcode scanners. Availability of barcodes and printers. At the end, training 2-level scanning for patient and medication identification.
Yes, as you can see that today you are taking medication from PICSes, going to the patient bedside, scanning and administration, the amount of work done behind, the amount of multidisciplinary approach were conducted between medical, nursing, pharmacy, IT, medical informatics. Huge work was done integrating, preparing the system, having the hardware availability for the entire organization just to improve the patient safety and the outcome.
Yes, and here for closed loop medication administration, as general workflow, it starts with electronic medical record, then with the pharmacy for verifying, preparation, storing in smart cabinets, and finally with nurses for administration and documentation. And the left illustration here, we can talk in more details. The cycle begins computerized provider order entry. The physician will enter the order on Yasashi, our health information system, and will reach to the pharmacist through the pharmacy panel to review and verify. Pharmacy technician will prepare the medication in a barcoded unit dose, then store it in automatic dispensing cabinets. For packaging and labeling, at DSFH, we have a PharmaBag device provided by BD company. The PharmaBag is packaging and labeling system. The system prints all of available information in data field on each bucket with any form of barcodes, can be data matrix, can be linear or JS1 data bar. The barcode showing a clear information about med ID, generic name, brand name, dosage form, strength, batch number, and expiry date. And for dispensing, all these unit items transferred and stored in automatic dispensing cabinets, which are available in nurse station near to the point of patient care. ADC system help a clinician safely and efficiently dispense the right medication to the right patient at the due time, as it employs advanced technology such as biometric identification, Only authorized staff can log into the device with their fingerprint and will be responsible for any activity done on the device, as all activities can be tracked and monitored. Barcode scanning on 2 phases, refilling phase and in dispensing phase, to ensure the right medication will go to the right patient. Also, one of the features we have in the device, a special storage space, especially for narcotic controlled and expensive medication. Also, there is alerting features. For example, a message will appear on the screen to alert the nurse, this is high alert medication, or this is lookalike medication, or this is an electrolyte, concentrated electrolyte.
Thank you. So if I will ask a question, I know that our full implementation of closed loop administration happened during October, November, December 2020-21. So those nurses who are here since before, what's the difference between the administration before and after now? Now it's more safe, okay? So how come it's more safer than before? How do you, what do you think, how it can be more safer? Yes, Dina, it's okay, you're right.
It's the right patient, the right medication, the
right
right dose.
Patient, the right medication, the right dose, the right route, going to the patient at the right time.
Yes, we are following the 7 rights.
Thank you very much. So one day, if Pixis or SRC is down, really our life is disaster, isn't it? 1 hour or half an hour. But few years ago, we were working without those technology. But now the technology became part of our daily life, isn't it? Yes. So yes, Dr. Marwa mentioned it very clearly that medication was packed and loaded and ready to be dispensed. Now what's going to happen when it comes to the assess patient prior to administering medication? So nurses should never administer medication without the assessment. Example, you are going to give a hypertensive medication to our patient, never give that hypertensive medication without checking the blood pressure. You are going to administer an diabetic medication, do not administer without checking the blood sugar. You are going to administer tablet digoxin, check the patient's heart rate before giving digoxin. So assess the patient prior to medication administration. Never administer medication without checking vital signs, because vital signs are vital. This will tell you what the patient is exactly going through. And yes, you need to take the portable computer, the barcode scanner, the complete medication tray, going to the patient bedside. Yes, we are always asking patient's name, isn't it? Yes, patients are verbalizing the name, especially a patient who can verbalize it. Number 2, you take the machine or the WOW, the work on wheel station or computer on wheel station, you get the barcode scanner, you identify the patient bracelet. That's the time the medication administration screen will open for you, isn't it? If it's not the right patient, the screen will not open for you. So the first checkpoint. Number 2, yes, the first level scanning is done. Number 2, you are going to scan the medication. Once you scan the medication, as Engineer Munir mentioned, it's 5 rights. If it's the right patient, if this is the right medication, if this is the right dose, the concentration, the timing, if there is any variation, yes, anything? Right route, thank you, Engineer Munir. If there is any variation, the medication screen will not open to administer. The slot will not open for administration. You see the amount of safety steps we have put in place for improving patient safety. So we administer medication. We document in the system before leaving the patient's bedside. So this is called closed loop. It means that closing all the loops for error, any kind of error. Because previously human interaction. Now the system is closing all the loop so that there is no more errors will happen. Also, not only medication, as Engineer Munir mentioned earlier, we implemented it for medication, human milk administration, and our neonatal staff are very expert in that. Number 3, blood administration, and number 4, taking sample label IDs for any kind of investigation. So here, when a mother, maybe sometimes the mother is discharged and the baby is still in NICU. Sorry. The mother will bring express breast milk. So what happens, the neonatal ICU nurse, she will take the barcode scanner, she will have the labels printed. Imagine the milk is like 100 ml, but every 3 hours, only 30 ml. So 3 bottles, the total amount is divided into 3 bottles with a proper label, proper expiry date. Thank you, Deborah. Proper label, proper expiry date. Then those containers can be kept in the refrigerator. 12 o'clock, 3 o'clock, at the right time when the feeding due time comes, that bottle will be taken out. The 2 level of scanning will be happening. Patient and the milk. Same thing goes with the blood administration. Previously, we were selecting, imagine a patient who is going to receive 5 units of blood products. And the 5 units are ready in the blood bank. Those unit numbers will be mentioned there. We are manually choosing which unit is in my hand. Sometimes there is a mistake in one number, we may go to the another unit. Okay? So now what happens? We have the QR code is readily available where we do the scanning of the patient to confirm the identification. The second level scanning, identify the blood product, the right unit number will be opened to start the verification and the administration. Also the sample collection. Previously, as you have said, 14% of the patients were having, or 14% of the total OVR were related to wrong sampling or wrong labeling. Why? Because our printer was in the nursing station. We take printout, take the blood sample, come out without a label, label it in the station, maybe 2 samples from 2 patients wrongly labeled. Now you have a portable barcode printer to be printed at the bedside so that the error will be minimized.
This is one of the dashboard we have distributed for all our nursing leaders. Microsoft Power BI dashboard. In this dashboard, nursing manager, they can see all the patient verified and medication closed loop details, sample collection, what is the status of the sample collection, what is the status of milk administration, and what is the status of blood administration. Whatever closed loop administration we have done, our nursing manager can monitor the status of that closed loop administration.
So how many of our bedside nurses, we know that there is an option in our computer PC like this? Raise your hands. Except the leaders. Leaders we know we have. Thank you very much. So just for your information, if you go back to your desktop, there is an option just like a shortcut of Google, closed loop. There is option to trace per unit, per month, per year. What is the compliance of bedside team regarding the scanning? So which percentage of medication or blood transfusion or samples were printed without the closed loop process?
Some of challenges that we met. First, choosing the right medication to package in the system to comply with medication safety standards. For example, we couldn't repack gelatinous capsules and photosensitive medication. Also, determining the type of packaging desired for each medication. For example, one of the challenges is barcoding the ampoules. Due to a small size, the barcode will be folded on the ampoules and couldn't be read by the scanner. So we added a small pouches for each single ampoules and attached the sticker, barcode sticker to it. Setting up the word stock of each item and define the min-max according to the word medication list with the average weekly consumption for each word.
Do you remember those days when your barcode printers were not printing proper labels? Many times we had our samples were rejected from laboratory. Do you remember those days? Every day we were making IT ticket. IT staff will come to the unit. He will fix the alignment. Next day again, the same thing. The sample labels were printed without the proper alignment. So when we did more and reported to the IT department, what was the problem? The setting was changing when we changed the user. When I log off and my colleague, Dr. Marwa, will log in, what happens? The setting will go back to the incomplete setting. So the company was invited and they did a permanent fixing of this alignment and no more issues regarding the barcode printer. So we are just talking about no change is easy. We will have a lot of challenges. How did we overcome those challenges? And the next one is slowness of the wow. How many of you are experiencing slowness of the wow every day? Raising hands, a lot of hands, isn't it? Okay. Yes, it happens because it works with Wi-Fi and at least better than before. You know how the IT department made a little bit of improvement? By the implementation of TS Plus. Do you know the TS Plus? So we all have the TS Plus shortcut in our laptops. So once we log in through the TS Plus, at least the performance is better than the regular laptop. And changing the culture. Before, like if you consider last year, we were going to the patient bedside without any computer, just only a tray with a medication. In 2 minutes, 3 minutes, you can go to the patient's room, give the medication and come back. Now what's happening? We need some extra time, isn't it? We need to take the laptop. Sometimes it hangs. Sometimes it takes more time. So changing a culture is not that easy, but at least if there is an improvement in patient safety, I will show you the next slide, how does this closed loop administration is improving the patient safety. And also I want to, maybe we did not mention, we also had a problem with syringes coming from pharmacy, isn't it? With a folded label, unable to read the barcode. Thanks to the pharmacy team, at least 95% of that problem is already fixed. A beautiful data, if you can see. As I have mentioned it earlier, almost 14% of the total OVRs were related to incomplete label specimen or wrong specimen. Now after implementing the closed loop, printing of bedside barcode printers, in January 2022, February, March, 3 months continuously, we have 0 incidents related to mislabeling of specimens. One of the most beautiful slide. Do you remember at the beginning we talked about that out of total medication error, 71% were near misses. It means that the remaining 29% of errors were reaching to the patient. The more near misses, the better. It means that near miss did not reach to the patient. So our intention is to increase the near miss and decrease the incidence. So if you can see, Q3 2021, our near misses reports were 71%, and we started implementing from September, October, November, December. You can see now we have reached up to 97 to 99% of near miss. It means that from 29% of medication error reaching to the patient, it reached up to 3% reaching to the patient. So do you think that, yes, we spend a lot of financial impact on buying those hardware, your time, extended time from each one of you, taking the wow to the patient bedside, but really worth having it because it is increasing or improving patient safety.
Yes, it's a great result, really. Thank you, Ms. Shaibi. And as a conclusion, closed loop administration can reduce manual errors in medication delivery and ensure all patient rights. Improving patient safety and the quality of care through improving accuracy in patient identification. More effective workflow between all hospital departments, IT, pharmacy, lab, and nursing staff. Time saving by giving our healthcare providers the tools they need to provide a safe and effective care. And finally, cost saving by managing the medication inventories through monitoring near expiry items, slow moving items, and this will lead to decrease the financial loss.
So the take-home message is, the take-home message, even if the transition to closed-loop administration require a certain amount of time from you all, thank you for that, and financial effort on the part of the hospital. You know, Dr. Marwa, how much is one Pyxis machine approximately? Up to 200,000 real for one Pyxis machine. And we have how many engineers we have in the? We have almost 47 Pyxis machine in the hospital. So why do you think that the hospital is going for a technology-based system? Because yes, as you have seen here, it requires certain amount of time and training and manpower, everything, but really it's worth having it because it is improving patient safety. Patient safety increases considerably and it reduces treatment and administration error, which save patient life, cost, and make it possible to deploy staff more efficiently. So together, the medical, nursing, pharmacy, IT, and really I want also to appreciate IT, especially Engineer Khalil, Engineer Mustafa Fadali, Engineer Subil, together, and before Dr. Tamadur, all the physicians who were helping. Our teamwork made our dream work, because together everyone achieves more. Thank you very much.
Thank you, Dr. Marwa, Engineer Munir, and Ms. Shaibi. So can we have a question from the audience?
Yeah, no, there is. I'm still waiting. Yeah, there is a question. Yes, Sarah.
Sorry.
Yes.
I believe Dr. Marwa knows about my situation. This is a question that I really wanted to ask for Engineer Subil. I'm Munir Malesh, sorry. Engineer Munir. I know this is not an escalation platform, just I wanted to know what will happen, because we are initially known as the OB-GYN unit, and every day we are receiving patients from delivery room. So once the patient delivers, the doctor from the delivery room orders their postpartum medications there. So once they transfer to the floor, we always have, I know not all patients, maybe around 60 to 70% of the patients that we're receiving from DR. When we receive these patients, their medications, most of the time are not seen in the Pyxis. So I escalated this before. I actually wanted to have a definite answer of how we can fix this issue, because the problem is the only answer I got from IT was to tell our floor doctors, our resident doctors, to reorder the medicine so we can see it in the Pyxis. And we're struggling with that issue every day, because not all doctors are cooperative and not all doctors actually are willing to help us reorder this medication, that my nurses are actually following them. I only have one OB-GYN resident handling 3 floors where all these OB-GYN patients are admitted. So I want to know what will happen, or if this issue will be fixed. Thank you.
Yeah, actually, your area is non-profile area. In addition to, most of the admissions are coming as temporary. Then they are transferring to room. This is the reason we are not able to transfer the medication to new visit.
Yes, Sarah, because in delivery room, you are using temporary admissions. Not always that patient get a bed, isn't it? Yes. The patient come to the DR, sometimes get admitted there, then transferred to the floor when there is a room available. So it's like a different visit. It's not the inpatient admission. But of course, I think delivery room and OB-GYN, they have almost 10 to 15 deliveries per day. So I think we need to have, No, delivery room is a non-profile area.
Yes, Ma'am Shaibi, Pauline with you. Actually, Engineer Munir, patients in the ER are admitted already in delivery room, not in temporary. We seldom get temporary admission if the patient doesn't have companion to do the admission. Most of our patients are inpatient. We only we ask the admission office to transfer them to the assigned room after the delivery. So for us, I think the responsibility of the physician to order postpartum medication, because patient is already admitted, is there. The thing is, I think we have something to fix with the system. Since we are automated, right? So it should be connected and all should be linked as soon as the patient is admitted.
Anyhow, we will consider this point again, and I will check with my technical team, and I will try to do my level best from my side.
Can I answer this also? I think there's one contribution factor in this, because the same thing happens for a patient coming from ICU to the floor. So why the medication are discontinued when coming from delivery room to floor is because the delivery room is considered higher to lower, the higher area to lower area. Whenever the patient is moving from higher to lower, the medication needs to be reordered by the physician. So in ICU, what we do is ICU physician must order the medication. So when he orders the medication, first we transfer the patient in the system, then he orders the medication. But if you transfer the patient from higher level to lower level without reordering, this is not something that will be fixed as a magic. This needs to be reordered. Actually,
this is what we are trying to explain, Pauline and Sarah. Because as Engineer Munir said, in delivery room, your system is non-profile. So the order going to the non-profile mode. Then you transfer the patient to the floor, which is a profile mode. So what is required? The physician, transfer the patient to the new area, new bed, then ask the doctor to order before transferring.
But we're talking about not all patients at the Shaibi.
Yes.
So if you are going to have all these patients, what I'm trying to say is if the patient is already admitted, as what Pauline said, it has to be connected in the system immediately. That's why it's automated. So if this is the case, it should be happening to all patients, but it's not. Okay, so why the medications of few or some postpartum patients can be seen and the rest are not? So
okay, so anyway, you are, we have opened this issue in this big platform. Now, medical informatics have no choice unless to fix it. Okay, so yes, Engineer Munir.
Yeah, I will check this issue again, and I'll let you know. Okay.
So, yes, Sarah. It's the highest platform, you escalated already. So we have a higher responsibility now. Yes. We will see, and at least what is needed to happen, the soonest, Sarah, the next patient, you have this scenario, give the complete details to Engineer Munir. Okay, the complete details of this patient. Thank you. Any questions?
One more here, ma'am.
In addition to that, Ma'am Shaibi, we also encountering in the emergency whenever we have a virtual bed patient and then they were admitted and transferred to another area, the medication is discontinued. So there's a confusion with the medication administration wherein the nurses are confused whether it is discontinued by a doctor, and then when we check it, it's discontinued by admission staff because they transferred the patient to another unit. So for example, we are infusing a potassium and then it's discontinued. So we need to verify again to the doctor, did you order a discontinued medication? When we check it, it's the admission office. So there's a confusion with that.
This is the main thing what Ms. Kadra mentioned. Admit the patient, then order. Not order in the virtual bed. Admit the patient to the room, then order. Because ER, again, going back with the same principle, ER is non-profile, inpatient is profile area.
Yes.
Yes, one more.
First of all, thank you, Dr. Marwa, Engineer Munir, and Shaibi for the great informative section.
Can you increase the voice?
We cannot hear. Thank you for the team for the great presentation. The concern is going to Dr. Marwa. regarding the fixes medication. Presently we are facing a challenge that the pharmapack medications are not available. For example, the tablets are still keeping in the fixes as a strip. This really making for the nurses to do the closed loop administration. Because we are working for closed loop administration, and if pharmapack is available, really it will be ineffective. And the second thing we are facing here, we are facing discrepancies. All managers, I hope, they are facing discrepancy in the count of medications. One of the reason is that the availability of pharmapack, if it is not available, the nurses, there is possibility to use the different batch number, and it causes discrepancy of medication quantity in the SRC and the fixes. How we can improve this?
First of all, for closed loop administration, all oral tablet, loose tablet, we make it as pharmapack. And for sometimes some items can't be repackaged as ionate dose in the pharmapack. So we apply the barcode application in all stations, and we make a barcode sheet in every WOW station, and to be available all the time to use it for the closed loop administration. You have also the barcode application. You can print the barcode for the item you will administer to the patient anytime. You have to be available all the time in every nurse station desktop now. IT department installed in all nurse stations. Also for the discrepancy from different batches, we talked about this before. This is before when they have an access, the charge nurse has an access to take and override medication in emergency situation, and this may cause sometimes she take a physical batch and charge it manually with different batch, and this will make a mismatching in the barcode. So, and the solution for this to just correct and confirm with nurses that any item removed as override from the boxes should be charged as the same batch she took physically.
Actually, still Jansi is not convinced.
Yes.
Their question, sometimes the oral tablets are still given in a strip, not in the pharmapack.
Yes.
I mentioned in the presentation that not all medication can be packaged in, as ionate dose. Photosensitive medication, we can do it, should be put in original pack. Some items written and should be kept in the original package, so we can't make it as a pharmapack. Inshallah, in the future, we will bring new version from unit dose packaging to solve this issue.
I got Dr. Marwa, but what we see here, when we implement fixes in the initial time, some tablets was really pharmapack. But nowadays, we are seeing the same medication, not with the pharmapack. I think the pharmacy have to look for this one, and please check with the each fixes. We are facing really this an issue.
There were some tablets coming in pharmapack, but now no more. So why?
Maybe staff shortage. I don't know. Maybe.
Yes, I hope.
Okay, so thank you, Jansi. Thank you, Dr. Marwa. Yes, these are the percentage, the non-compliance of closed loop. Yes. So those will not be able to administer via closed loop. Thank you very much. Yes.
Thank you. They have the barcode application. They can print the barcode.
They have the barcode
yes,
application.
You have the barcode application on all nurse station. You can print the barcode anytime when you take the medication. You can print the barcode and go to and administer the patient and scan it.
Yeah, it's an additional task. It's an additional time. Okay, that's why if, thank you, Dr. Marwa is saying that they're getting some new device which can cover all medication. Yes. Let's hope to have that early.
Yes, inshallah.
So thank you very much.
Thank you, Ma'am Shaibi.
Thank you, Jansi. Jansi, leave the phone, microphone, Jansi. خلاص يا Jansi. Now I'm asking all our great speakers, would you please come here to the stage? Now I'm asking all the great speakers to come to the stage, and I'm asking Ms. Khadra to come to the stage, not to give the trophy. Today she is going to receive the trophy as a thanks memory for her great presentation. Let's have 10 minutes break and we will be back 3 p.m. inshallah. Thank you. حبيبي قلبي قلبي. Do you have a mic? Thank you.
Ay, oo, akala ko magkaka-picture Ladies and gentlemen, may I have your attention, please? Our next presentation is about to begin. But before that, may I present to you, allow me to introduce the presenter. She is a former ESL teacher for 4 years, teaching Korean, Chinese, Japanese, and Taiwanese students in different levels. A private nurse of one of the biggest shipping line, a call center team leader for 3 years, a former speaker in 5th International Red Sea Ophthalmology Symposium held last November 2019, staff nurse for 2 years in DSFH with a total years nursing career, 8 years in nursing career. Without further ado, I would like to welcome the presenter to deliver the presentation. May I call on Ms. Jara Bernadine Folido.
Iba, you can take this one. Let me show you. This is the one that to change the, and this is the one to bring it back. Okay.
This is the one to play.
Okay.
Okay. Hello, good afternoon, everyone. So before I start my presentation, I know everyone is full now, right? Am I right? We eat a lot. So before I will start my presentation, I will ask everyone to stand. We are sitting for so long, sorry. For those pregnant, of course, exception. And madam, it's okay. You need to stand up, madam. We will just have a short exercise because we are learning a lot since in the morning. So I want to end this session. We are still energetic, okay? I will teach you some few steps only. Then I will have the music later. Ready? Everybody's ready. Stretch your arms. All right. So we're gonna count coming 1, 2, 3, 4. And then, yes, 1, 2, 3, 4. Touch your chest for 4 times also. 1, 2, 3, 4. And then wave, because this is the end session. Hello, going home. 1, 2, 3, 4. And then you just tap a snap. 1, 2, 3, 4. Okay, it will be left and right. We'll do it 4 times only, just to make you exercise. All right, I will have the music here, because the music cannot be there. Guys, are you ready? Very good. I love the energy. Wait a minute. You will follow me, don't worry. Okay, ready? Can everybody hear the song? I will repeat. Is it clear? Or should I hold? Yeah, because I'm supposed to. Sorry guys for the music. It's okay. Okay guys, I have a very loud voice, don't worry. Ready? All right, everybody, thank you so much. More? Your exercise, okay. Let's talk about the importance. Let's proceed to the serious part. Let's be serious for a while. Okay, the importance of lifelong learning. Do you believe that we are all a lifelong learners? Yes, yes? Well, yes, no? All right, yes, yes. Don't mind my stick, huh? I always bring stick anyway. Okay, we are all a lifelong learners. Why? Because learning doesn't stop just at the moment. Day by day, you are learning daily. Even sitting here, you learn since in the morning until now. You are learning. Am I right? All right, very good. I will ask one by one. Don't worry, I love go to the audience. Going to the audience later, so you will be awake. Sorry, proceed. Okay, let's talk about the benefits of a lifelong learning. Do you have this in mind? Because we are all a learner. We need all of this. First, number one, what do you need to build? Of course, if you want to ask something, like for example, our procedures, you don't know how to do the right CPR. Of course, you need to improve your skills, and of course, you need to ask. You need to ask anyone that is professional that will help you to learn or gain the right way to do CPR. Am I right? Yes, yes? Okay. So you already have those. You have the memory since you are learning. Since you don't have a license yet, you are learning from school. How to do the CPR, you were seeing images, and you will also do the practicum. But, of course, enable for you to be professional or how to do the right way of doing the CPR. Of course, you need to have all the knowledge to practice, not only to stop what you are looking. Okay? The second one, to nurture your curious mind. Let me just ask you, Albert Einstein, do you know Albert Einstein? The scientist and the great philosopher. The number one rules of Albert Einstein was, this is the life rule of Albert Einstein anyway. Let me go through. Yes. This is the number one amazing life lesson that Albert Einstein wants for every learner to remember. Always follow your curiosity. Why? Because when you're curious, you will tend to learn and you will tend to discover what you want to know. For example, since you were young, you will be curious what your mother is cooking at home. Maybe your mother's cooking an egg or cooking a meal, and you want to know. So your curiosity will come. So when you have this curiosity in mind, you will tend to ask, Mom, how did you cook kabsa? How did you cook an egg? Of course, from that, you will have the learning. So we are all curious in any ways. So that's why we are gaining our knowledge. Okay, let's move on to benefit number 3. Number 3, it means to open minds and increases wisdom. So when you have this curiosity in mind, you will tend to get more information what you want and what you want to learn. Of course, on opening your mind and increases your wisdom, you need to take all the information from the people or the person that you want to acquire your knowledge. And then it comes to improve your memory. And remember, your memory is not, you will not take all the memory all the time. You will tend to forget. But if you're doing that in practice with the proper training or proper instructions, you will be confident enough to perform, to cook, or even just to say a lot of things because you know something. Okay? Let's take this lesson. So lifelong learning, is it a superpower that elevates you to a new heights? When you are kids, you were here. You get maybe high school, middle school, until college, until you will be here. The higher you will get, the more curious you will become, and the more knowledge you will gain, and you will apply it to practice, and you also spread it to your workmates or even to your colleagues, so they will learn from you. And you were learning to each other. Okay? Dr. Hussein talked about the CPD. Why we are talking it again? Because CPD is a lifelong learning. We don't stop just today because we learn what is CPD, what are the activities of CPD, and kinds of CPD. We don't stop from there because we are all professionals, but we are not telling we are excellent already. We are keep seeking for excellence, and we are keep on seeking for perfection, but nobody's perfect. So that's why we are all taking it one by time. Stepping a ladder is just like that until you reach at the top. So I will just take information. I'll just give you the information, but Dr. Hussein informed you all of this already. So CPD is already a holistic process, a training for us professionals to gain knowledge and skills. So I will go down. I will ask anybody around, because I have also curiosity in mind. So what is the difference between CPD and CME? Si ate? Yes, madam. What do you think is the difference between CME and CPD? Miss, may I know your good name, madam?
For me, I think the difference between CPD and CME is for CPD, continuous professional development, right? And for CME, continuous medical education. So for continuous professional development, we are not only focusing on the skills or knowledge that is shared like theoretically or knowledge base. So it's more like broad, like it's professional development. So it doesn't only cater our skills and competencies. But for CME, it's like advanced learning. It's giving you more knowledge and like to help you enhance the skills that you have already.
Okay. Thank you, Ms. Van. And other else? No. Let me go. Let me go and wake them up. Ma'am, good afternoon. Ma'am, what do you think is the difference between CPD and CME?
As what you said, CPD, it's a broader issue, while CME, it's like a definite topic that needs to be discussed. Like, for example, the topic for today is about ophthalmology procedures. So the ideas or the teachings or the learnings that you will get is specific While for the CPD, it's broad. Anything that can help a certain person or a certain professional to grow more in his or her field.
Thank you so much, ma'am. Your good name, ma'am? Thank you, Miss Marlene. Okay, so everyone is curious, I guess. What is CME and CPD? Am I right? Yes, yes? Or everyone knows? Okay, let me just have this picture. Okay, I will talk about the difference later. So when you talk about CPD, you will have a workshop, a training for us to develop our skills, our knowledge that we got. So we will put it into the skills and practice. Then that's the time you can coach anybody. If you are already capable to give the information to other colleagues or other people, you can coach. As you've learned earlier, it will be a one-by-one, coaching and mentoring. So you will give the information that you all got, you will tend to share. Then, what you are sharing, of course, the knowledge that you got. For example, there will be a beginner, a newcomer in our hospital. What you will teach them? Of course, aside from welcoming them to our unit, you need to also give them overview. Aside from the orientation, of course, in my own experience, when I was still in the orientation period, I was also amazed with the system. I don't know anything. Even up until now, for 2 years working with the system, I still have questions, but we are keep learning. So we are mastering also our system. Then, for acquiring all those knowledge, so you put that one in teaching, so that people that you are teaching also will learn. So like if you will be a preceptor to any of new members to your unit, new nurses, you will also give them what you learn. Of course, we are not that perfect. So we give room for mistakes. So we just give them what we also learn from time by time. Okay, let's talk about the benefits. What about the benefits of CPD? First, it's competitive edge. When you say competitive edge, we are not competing to each other who will be the best and who will win. No. What do you mean by competitive edge? You have the profession, or each of you will know. For example, let's just say also cannulation. Let's just say cannulation. One of the new staff or the new member, it's not that good or don't know well or not practiced well. It's not that you're competing because she or he doesn't know. You are helping each other, so you will step the same ladder. You will not left any behind. So you will go together. So if you will say competitive, it means you're competitive enough to give teachings or learning to your colleague. Not that you are competing because you're good or best or better than them. Next, it's cost effective. We are here for also acquiring CPD and CME, of course, for our licensure. Did we pay anything? No. Am I right? We are not paying because the hospital provided us. So we are not paying for any 300, 100 or anything. But we are gaining knowledge out from it because the hospital itself want us to have a good role model and standard of nurses. Next, it will be increases your growth. So if you are planning to be a nurse manager, a director, or a step-by-step, you will also need all the knowledge that you need. You need to gain it from your nurse manager if you want to be a nurse manager, or if you want to be a director, or what level you want to be. Or you want to be from nurse to a doctor. So you will need a growth and knowledge also. So it takes time. Then measure your performance. For example, you will have an exam. You're good in multiple choices, but you're bad in essays. So, to balance, to have the equilibrium, you need to be also focusing on your weakness. But when your weakness, you need to ask from others. You can't even balance with yourself. Of course, you need some lessons from others on how to take it, how they do it good. If they're good in essay and you're good in multiple choice, you need to ask them how they do it. So you can also be balancing your performance, so you can get why you have average, why they got best or excellence. So you need to acquire. Next, to improve your standards. Of course, our profession, by every year, every 2 years, we need to renew. So we are also not only taking the CME, but of course, we will have our own professionalism. It goes ladder by ladder. Okay, let's talk about now the difference of CME and CPD. Actually, CME was the beginning. CME stands for Continuing Medical Education. CME is the ingredient to CPD. They're no difference. The CME is part of it inside. You see the cycle outside. This one means holistically, we're taking the professional development. Inside it is our CME. Why? We are practicing day-by-day basis, not only in our work, so that we can gain all the development process. It's a part of CPD. Our CME is a part of it. That's why it's education, the skills, and also the practices that you will have. So Dr. Hussein talked about it already, this cycle. But I just want you to realize why we have this circular image, like a FIFA soccer ball. Because you just imagine how the ball goes rolling. So also, our continuous professional development doesn't stop. It goes round and round, and it goes by time. And it might be stopped by some other point, but it will keep rolling. It never stops. And of course, there are steps on it. Dr. Hussein emphasizes the steps and what are conclusion on this side. What do you need? What do you need to improve? How to assess yourself? And of course, you need to plan and do the practices and check by yourself. CPD is all for yourself and for you to give a good standard, a good role model to where you are working. Okay? Before we end this session, I just want to thank everyone that are still awake until now and also still listening up until now, to our great leaders and also, maybe not here anymore, our doctors, Madam Sholi, Madam Jamaica, and Madam Basam is here, and our great leaders, Madam Shaibi also. So I will leave you this message. We have 8 tips to boost your learning. Do you believe those who take online courses of learning and management? We all have different learning style. Maybe one of you learns by visual, maybe learns by listening, or maybe learning by reading. So we all have different kinds. So these are just tips. Spaced repetition, it means you break up your studies than doing it one block. For example, you have an exam tomorrow, and you just want to study today, tomorrow is the exam. Do you think you will pass? Yes or no? No, I guess. Or maybe, if you will be lucky, you will get a half of the grade, average.
Excuse me, 3 minutes.
So, that's why, than to take it one at a time, study day by day, because you will know when is your exam. So before your exam, a week before your exam, maybe you take 1 to 2 pages and do it the rest later. Because your memory is not that much. You cannot even memorize one entire topic in a day. It's impossible. That's why. Next, retrieve. So you just recall. You recall your memories through your reflection and conversation. You talk to yourself. What am I reading yesterday? Just to give a lesson. And then you try to focus. Focus for 25 minutes, have a break, and go back. Because you have also a time limit to get bored. You keep on reading, you can keep on reading, but you are not even putting anything here. Then, recognition. You keep on learning, your strength, your growth, and mindset is there. For example, your mindset, I want to have an excellent test result tomorrow. So you have to have a mindset. I will have a test on Friday. Every day, I will take one chapter somehow. Then, mental models. You start with a big picture. Maybe you will start to have a details of filling up. So what will be you want to learn? From there, mentally, you will take the outer look. Then, what are the contexts to study? Maybe you are studying, you want bullets, or you want detailed, so it's up to your study style. Then, of course, we are all lack of sleep. But sleep is very helpful for us to gain more memory and also to acquire the knowledge that we take from before. And try to exercise. Exercise, not just to exercise the lesson. Exercise yourself. Energize yourself day by day. Okay? So before, that's the last slide that I have. But I will leave 3 letters with you. Just remember KSA, not Kingdom of Saudi Arabia, but K stands for knowledge. If you have knowledge, you will have S. What is that? Skills. Very good. So if you have those learning and knowledge, you can put into practice. The last one will be your A, your attitude. Attitude in every way, not to step deeper, not to go up, just to be yourself. All right, thank you for all the slides. Get a short? Thank you so much.
Thank you, Ma'am Jera, for the interesting and informative talk. So now we come to question and answer session. So any question from our audience?
We have a question from the audience.
Hi, Jera.
Hi, Madam. Good afternoon.
Simple question.
Make it difficult.
As a bedside nurse, we all know that our organization is offering huge or a lot of CME hours and CPDs, right? So
Yes.
as a bedside nurse, how would you encourage our staff to join?
Yes, thank you, Madam, for that
you.
question. Actually, all of us has always our pressured is the time. We all are busy with our different times. Maybe we're working, maybe you will also have duties outside, but what we have to do to encourage them, not because of the CME, not because we are gaining points from it, because if you will be here, you will gain anything out from what you are just thinking. So for example, I'm sitting here. Do I learn something? Then what about those people that don't have anything, encouragement that they want to come? Maybe one staff nurse from night shift, I cannot attend because I came from the duty. She has a reason, but the question is, does she have the information that we got today? Then she just sitting or lying there at home. Because personally, each one of us have our own learning. We want to learn, or maybe tired today. We have a different circumstances to deal. So I cannot say, I want to encourage everyone, but not everyone will participate. It's the same thing that you're talking to a lot of people here, but not everyone is intentionally getting what your point. It's the same thing. Why would I tell you to come if you will not gaining also? Yes, madam, did I answer your question? Anything? Anyone? Oh, sit beside madam.
Much. Can I ask our great presenter to come to the stage? We want just to say thank you and give you a small memory to remember us. Madam Shaibi, Miss Khadra, would you please come to the stage?
My graduation day.
And Mr. Lee.
Now it's a time to thank our great moderator. Would you please come to the stage? Dear friends and colleagues, really we enjoyed the 2 days together, the 6th Nursing Symposium. I think this is the good memory for us, and we will wish for all of us to be meeting next year in the 2nd Faqih Congress. So see you inshallah next year. Thank you. Come to the stage, come, all of you. Can I ask all attendees to come to the stage? Dr. Saleh, come to the stage.